Здравствуйте, уважаемые.
Distinguished colleagues, greetings. I'm happy to greet you today on our conference, International Conference Epidemiological Well-Being. And as all of you know, we planned to hold the conference as it was before on the regular basis once in 2 years. And we planned to hold this conference in April 2020, but the world situation, the situation related to pandemics, has changed our plans. And together with you, all of we were coping and battling and I'm grateful to you, and I'm very happy that today, on the basis of all of our requirements that were built up during the last year, with participation of the Scientific Society of the International Best Practices, we are able to hold our conference in a complex online and offline combined format. And I want to greet all of the participants, and today in our hall there are 200 delegates from 7 countries from Eastern Europe, Central Asia, our partners from the United Program or UNAIDS, UN program, WHO program, and in an online regime. We have participation of more than 4,300 participants from more than 30 countries of the world. We have representatives of state organs, international organizations, business community, and we are performing online broadcasting and webcasting of our event. I want to tell you that together with us, we are seeing more than healthcare, more than 1,000 representatives of science, 500 state officials and governing bodies, and 310 representatives of community organizations, 22 business representatives, and about 50 representatives of mass media. The conference is devoted to the main challenges of our everyday life, of our everyday work, and this is a very important event in our calendar. And I really hope that these days, and we are having 2 days, 20th and 21st of April 2021, will be devoted to the very important issues and questions, and we are hoping to be engaged in the fruitful discussion on the topics of epidemiology, epidemiological science, because I think that, and I want to state that 2021 is the pandemic year, still not a post-pandemic year, although I wanted to name it post-pandemic. And the conference will be devoted to a broader set of questions and issues, because the infectious diseases, these topics, prevention and combating diseases is the most topical issues. We have 21 concurrent sessions in all aspects of fighting epidemics, herd infections, introduction of international sanitary rules, realization of Russian and international programs, and anti-microbe drugs. I want to thank of the participants, and now I want to represent the guests, honored guests of our conference. Shannon Hayder, the support of the UNAIDS, had Abdul Mazadan Jamalidik Abdulovich, Minister of Healthcare of Tajikistan Republic, Lena Manukovna Onushan, Deputy Minister of Healthcare of Armenia Republic, Alexander Alexandrovich Tarasenko, Deputy Minister Care and Social Development. Sanitary. And of course, the year 2020 and pandemics have proven and showed to the international community the necessity of the facilitation of international situation of rapid coronavirus infection. The countries throughout combat the enemy, the COVID-19, and we understood for how it is important to support each other and to stay in the constant dialogue, operative interchange of information on the outbreaks, proofs and disproofs of laboratory data on diagnostics. These are very important topics, but still coronavirus is not only one threat to the well-being that is posed to the people in all countries. Pandemics, COVID-19, has seriously negatively affected the healthcare in many countries and can push on the global sustainable development goals 2030, and coronavirus infection and this infectious disease may affect the combating of other diseases, including the HIV and other conditions. According to the data of WHO, in certain countries, the accessibility of HIV treatment and support for the patients and people with HIV was affected by 75%, and one of the most important the scope was planned vaccination and immunizations. More than 100 million of children could miss their vaccination because of the campaigns and against epidemics campaigns. Although we have a decrease in several infections related to the status of the current events, and we say that for example, measles is going down in Russia, and we see that this is also very important and actual topic for us. And the supreme governance of Russia was paying due attention to the immunization, to the healthcare of Russia, and especially President of Russian Federation Vladimir Putin and the government of Russian Federation. And now let me please to open our conference by two very important greetings that are really important for us. That is the greeting from the President of Russian Federation and the greeting from the government of Russian Federation. To the participants and facilitators of the International Conference Epidemiological Wellbeing. Distinguished friends, dear friends, I want to heartily greet you on the International Conference Epidemiological Wellbeing. The problems that are covered by the conference are playing a huge role in all the community and are striving for the international cooperation. The broad pandemics of coronavirus is proving that not one state, even the best developed state, not solve this problem and issue alone without cooperation with international partners. Russian researchers, Russian agencies, pharmaceutical agencies and healthcare agencies have a unique set of experiences in fighting not only coronavirus but also other diseases, flu, measles, HIV and so on. And our colleagues are openly posing their knowledge and sharing their knowledge and sharing the knowledge with the participants of the whole community, international community. And we hope that the result of your cooperative work of this event will serve to the protection of healthcare and well-being of people around the world. I wish you success from the President of Russian Federation, Vladimir Putin. And you know, during the whole period of pandemics, the operative solving of tasks and issues on coordination of activities was subject to the operative staff of the government of Russian Federation, led by the Tatiana Alexeyevna Golikova. She was planning to be together with us, but taking into account the day of tomorrow, that is important for our country, Tatiana provided for a greeting for us. And distinguished colleagues, against the pandemics in the first line. In the first days of the coronavirus pandemics, Russian specialists made it real and developed the kit for diagnostics, and we managed to save many lives of our citizens. We are the first country who managed to develop and register the vaccine against COVID. And as pandemics has shown, the best way to cope with the pandemics is achieved by the countries with centralized means for fighting against the viral diseases. And this was the basis that was laid during the Soviet times, and on this basis we are building on to preserve the lives and of our citizens. And although we were fighting against the pandemics, in the focus of our attention were the other infections. We've seen the decrease in morbidity in many diseases. And only in working together we are able to fight the pandemics further, and we are able and we are eager to share our knowledge, to search for the new means of diagnostics and prevention of infections, and we are ready to invest into the operations of the UN and other international organizations. I want to wish you success in fighting these threats. Deputy Head of the Government of Russian Federation, Tatiana Golikova. Distinguished colleagues, speaking about sanitary and epidemiological well-being, we need to especially stress the coordinating and leading role of the WHO, World Health Organization, in organization and realization of efforts in protection of citizens and people around the world. And of course, we are rendering support in international cooperation and organization and facilitation of studies of new coronavirus infection. And I want to state that the consolidating and coordinating role of the WHO from the first days of this disease provided for counteracting, and from the first days of the outbreak of the disease for creating of many working groups along different directions to make the experience, the best experience and best practices acceptable to all of you. And now I want to introduce Tedros Adhanom Ghebreyesus, Director General of the World Health Organization, with his introductory word.
Dear colleagues and friends, when the global HIV epidemic erupted 40 years ago, life-saving antiretrovirals were developed, but more than a decade passed before the world's poor got access. Life-saving vaccines for COVID-19 are now giving us hope for ending the pandemic. But we are still learning the lessons from HIV in terms of the importance of equitable access to these life-saving tools. Around the world, the devastation caused by the pandemic has been compounded by severe disruptions to essential health services, including for people living with HIV and TB. The pandemic is a setback to our shared commitment in the Sustainable Development Goals to eliminate HIV, sexual transmitted infections, and viral hepatitis as public health threats, and to end the global TB epidemic by 2030. I'm happy to note that the accelerated effort to develop COVID-19 vaccines has reinvigorated hope in promising mRNA vaccines for HIV. I would like to thank the Russian Federation for hosting this important meeting and for its support for the Global AIDS Strategy for 2021 to 2026. And we look forward to your continued support in the lead-up to high-level meeting in June. Thank you, and I wish you a very successful conference. Spasiba большое.
Thank you so much. And in this year, UNAIDS is celebrating its 25th anniversary. That means that a quarter of the century, this organization is solving global tasks on the agenda in the healthcare. And UNAIDS is one of our most important partners. And these conferences, for example, as the other conferences, are held together with UNAIDS. And for almost 10 years together, we are rendering help to the countries of Eastern Europe and Central Asia in combating HIV, AIDS, and other infections. And now we want to listen to the greeting word on the video from Vini Bianima, Executive Director at UNAIDS. The floor is yours.
Hello. It is our great pleasure and honor for UNAIDS to join the Russian government in convening this very important conference. I'm sorry I could not be with you today, and I'm grateful to my Deputy Executive Director, Shannon Hayder, for being there to represent UNAIDS. While we might not see several issues in the same way, I am very grateful for Russia's engagement as a UN member state in our board, and also Russia's strong commitment to ending AIDS and Russia's support to fighting AIDS in the region. And in coming months, I hope to visit Russia personally. Let me highlight critical issues that are important for all countries of Eastern Europe and Central Asia. First, in recent years, all countries of the region have made progress on HIV. Also, in recent months, we've seen countries of this region making progress against COVID. But let me be clear, we are still not on track to stop COVID or to end AIDS. But the global crisis we are facing today gives us the opportunity to get more serious and fight to end both epidemics. For COVID, this demands that everyone who needs to be vaccinated everywhere is vaccinated, not only those in rich countries. For HIV, this demands that even in the absence of a vaccine, we use all the tools and the evidence-based programs to get every country and every community back on track to end AIDS by 2030. If we've learned anything from COVID, it is that it takes all of government and all of society to end an epidemic so that nobody is left behind. This is the kind of social mobilization we need to reestablish and end AIDS in every country in Eastern Europe and Central Asia. Second, UNAIDS Program Coordinating Board has just adopted a new global AIDS strategy by consensus. This would not have been possible without the support of two member states in this region, that is Russia and Belarus. While I appreciate that there are elements of the strategy that Russia did not support, there are so many there that Russia did support. There's so much in the strategy that is to be implemented with urgency in Russia and in every country of Eastern Europe and Central Asia. 95% of people at risk for HIV should use evidence-based HIV combination prevention services. 95% of people estimated to be living with HIV should know their status, and 95% of people diagnosed with HIV should be on treatment. These are not just aggregate national targets, they need to be achieved in every population and every age group by 2025. And less than 10% of people living with HIV and key populations should experience stigma and discrimination. These are just some of the targets in the Global AIDS Strategy, the most ambitious targets ever adopted by the international community. Reaching these targets by 2025 will put every country and every community on track to end AIDS by 2030. I hope all the targets in the strategy will be fully reflected in Russia's new state strategy against HIV/AIDS. Third and finally, I have two requests about the United Nations General Assembly high-level meeting on HIV/AIDS in June. This meeting will be the greatest test of global solidarity to end AIDS. All the previous political declarations on AIDS included ambitious targets and explicit terminology that not all countries could accept, but that all countries supported by consensus. So I'm asking all of the governments at this important conference to engage in the negotiations in New York on a bold, new, ambitious political declaration that does not lower the bar and that will advance the momentum to end AIDS by 2030. I thank you all, and I wish you a productive and successful conference.
Distinguished colleagues, over the previous year, the aid to some neighboring and foreign countries has also been delivered through the interparliamentary interconnection, and the Federal Council of the Russian Federation played quite a role here, and I would like now to give the floor to Inna Yurina Svetenko, the chairperson of the Committee of the Council of the Federation on Social Policy. Inna Yurina, the floor is yours. Good afternoon, distinguished participants to this conference. I'd like to welcome you on behalf of the Federal Council and the Federal Assembly of the Russian Federation. 2020 saw some new infectious disease, coronavirus, COVID-19. It has been quite a test to the whole world as well as to the system of healthcare. It influenced all the parts of our life, and we had to consolidate our resources, our scientific knowledge, to develop the test systems, the medications, to search for some innovative technologies and methods. The Russian Federation prevented the outbreak of diseased cases and the death. And we conducted some large work. And first and foremost, this is due to the work of our medical community. While we were fighting the pandemic, we came up with the opportunity to establish a specific format of the medication registration that was supposed to prevent and cure the diseases that were quite dangerous for the people. To increase the stability of the national healthcare against the epidemiological threats, we adopted the strategy on the development of prevention of infectious diseases up to 2035. And this will serve as a platform to organize our activities and prevent the spread of the diseases, of infectious and other diseases that can be controlled by the means of immunoprevention. I'm sure that during this conference, the participants will discuss the pressing epidemiological issues, the tasks that are connected to the epidemiological well-being, as well as they will exchange their experience and find some ways how to be efficient in this way. Distinguished colleagues, I would like to send the regards from the Deputy Chairperson of the Federation Council, Madam Karelova. She wishes everybody to have some fruitful work, interesting discussions, the enforcement of business contacts, and of course, please stay healthy. Thank you very much for your attention. Inna Yurina, thank you very much. Dear colleagues, I would like to say a couple of words about the project that has been underway for a couple of years, and we focused on it quite a lot. This is the program of the aid to the countries of in Eastern Europe and Asia. We've been doing this program since 2013, and more than 2 million people in Eastern Europe and Central Asia got some help when it comes to the prevention of HIV and AIDS. And more than 3,000 people were trained according to the Russian methods. More than 100 different types of items of agents and medications has been transferred. And now we would like to screen some video that will show the results of this very important project for us. The situation with the spread of HIV in the Eastern Europe and Central Asia continues to be tense. The number of infected cases continues to rise. Such infections as viral hepatitis. And a lot of people still miss and lack the medication. The labor migration also affects the situation because the families of the migrated people have to get some information how to preserve their health. In 2019, the humanity faced the coronavirus infection that turned into a pandemic and a global threat that is currently being fought by the whole planet. The fight against COVID-19 didn't only divert the resources from the treatment of HIV and AIDS, but also it has demonstrated that the presence of established systems on the fight against the infectious diseases allows us to be efficient in the fight against the pandemic. To be efficient in this response, the government of the Russian Federation decided to financially support 6 countries in the region: Azerbaijan, Armenia, Belarus, Kyrgyzstan, Tajikistan and Uzbekistan, to deliver some aid to people that live quite far, and it all was due to the mobile clinics. The Russian Federation provides the clinics with medication express tests. It also pays for the transport. The Russian specialists consult and monitor each and every car that is going out. And in these cars, there are 3 rooms that can be used for some medical help. Today, 13 mobile clinics provide help and support. The program of the technical support to the countries of the Eastern Europe and the Central Asia when it comes to the prevention and control of the HIV is supported by UAIDS, and 240 people got the help. More than 200 people are screened on a daily basis. During the first and second stages, and in cooperation with the Red Cross and other subsequent organizations, we started to launch the educational centers for migrants. With the participation of people in Tajikistan, we also introduced the electronic system of the epidemiological surveillance when it comes to HIV. The equipment has been launched and established. Armenia. 3 mobile groups and teams when it comes to monitoring and HIV testing are working in Armenia. In Yerevan, there is a special center that is equipped with everything needed to that end. With the expert support from Russian specialists, Armenia has developed numerous normative documents and educational training materials when it comes to the diagnostics and epidemiological surveillance. The system of remote training and epidemic surveillance has been established. And in Kyrgyzstan, we see that the diagnostics has been increased 7 times. When it comes to vertical transmission of HIV, we see that there are different sets of activities when it comes to medical aid to children. We also managed to improve the situation with the HIV-positive children. In Kyrgyzstan, we aimed at improvement and development of the labs when it comes to the diagnostics, and we also have transferred to some cutting-edge systems when it comes to HIV testing. Belarus, it has joined the technical program in 2016, and the main development since that is the mass awareness campaign and it is aimed at a popularization of testing. In spring 2017, in the pharmacies in Belarus, they were appearing the express tests on HIV, and it all allowed to interpret the results just at home without visiting a clinic. In 2020, Uzbekistan joined the program of technical support, and the Ministry of Healthcare signed a memorandum, and afterwards the ceremony of the transfer of the first mobile diagnostical center has been conducted, and the first mobile center has been transferred to the authorities. Over the years of work, the program of technical support has significantly improved the situation with the HIV infections in these countries. The efficient system of express testing has been established. The prevention of HIV among children and women has been improved. Also, the surveillance of migrants has been improved, and we've established some professional relations between the clinics and the health workers and other people. And we see that the awareness campaign among the people in rural areas has been underway. Distinguished colleagues, we've seen the work of medical staff in different countries, and we know that the aid that has been provided by UNAIDS jointly with the Russian Federation on the transfer of knowledge and experience, as well as mobile labs from the Russian Federation to a number of countries, it was very relevant and pressing, especially in demand during this difficult period. Our mobile centers and the lab testing clinics helped people that live very far away in some mountain territories. Usually, there are no doctors to render this help, and the mobile centers is the only opportunity. And during this period, we've all been working as a united team in the significance of medical staff, of epidemiologists, microbiologists, and all the medical staff, GPs, the midwives, all the doctors. The help of all these people was very important. During some just calm times, we could have underestimated it, but now we cannot overestimate it anymore. It is not possible. And jointly with the foundation, we've prepared some awards to mark the best people that were assessed by the Special Commission on the Assessment of their Efforts. And now let me conclude this ceremony, this opening ceremony, with the thankful letters and some tours to our neighboring countries, to the sightseeings in different countries, in Tajikistan and others. We will give out these awards to the winners of this award. To reward the employees of the mobile clinics in Armenia, we invite Tamara Onsipan, Lili Daftan is also to receive the reward. Marine Osran is among the winners. To mark the best employees of the mobile clinics from Kyrgyzstan, the first winner is Bura Ursalaeva. We invite Asanbek Azir Aypiri to come to the stage. Venera Murtamilova, please come to the stage for the awarding ceremony. Timur Sharipov is also among the winners among the employees of mobile clinics in Tajikistan. Savdat Vatanova, please come to the stage. And also, we would like to thank Soania Ahmedzadeh, and we would also like to kindly ask you to give her the certificate because she's not present right now, but we would like to give her this award remotely. Distinguished Anna, distinguished colleagues, dear friends, dear compatriots, I'm very thankful to the government of the Russian Federation for financing this very important program. And it is especially pleasant for me to be among those doctors who've got the certificates, among other colleagues from different countries. My colleagues that work in the same mobile clinics, my colleagues from Armenia, Tajikistan, Uzbekistan and others. As a gynecologist, I'm very happy that I can help girls and women, ladies, those who don't have the opportunity to visit a doctor for different reasons. And the mobile clinic helps people. I would also like to specifically state that we would like to see the continuation of this project for many years to come. And we would like to deliver on our responsibility and liability as doctors. And we would like to continue to work tirelessly to preserve the lives and health of people in our region, in the Eastern Asia. Well, I meant in the Eastern Europe and the Central Asia. We've always got some very thank you words from our patients. We see in their eyes and we can feel it in their hearts that they are very happy to once again regain their life, and they're very thankful for our knowledge and for our medical services. And I would also like to wish all our countries to continue this work jointly. Once again, I'd like to thank the government of the Russian Federation for this program of technical support for the mobile clinic. And I would like to wish all of us to be healthy, to be successful in the future. And please, good luck. Thank you, and thank you for your attention. Distinguished colleagues, by this, we mark the conclusion of the opening part, the welcoming part of our session. And if you don't mind, then let's turn to our first plenary meeting and to the presentation that we've drafted for you jointly with our colleagues to assess first and foremost the current situation and to also consider the vectors of the movement forward for the future. Dear colleagues, please, could you show my presentation? So, what we can see and what we know, what we've known, and what helped us to forecast quite a long time ago the epidemiological unwell-being. This is the dynamic of biological threats in our region. And you can see on this slide different cases of plague and also different cases of polio, of cholera, measles, frenzies, and many other infections that haven't been presented in here. The changes that we've been observing and that are connected have happened, and it happened indeed. From the end of December of 2019, we are working under absolutely different conditions as compared to the previous ones. As of today, if we talk about the situation in the Russian Federation, well, more than 12 months have passed, and we can say that the development of the novel coronavirus infections, if we calculate the morbidity for 100,000 people, well, we see that today we occupy the 79th place across the whole world, but we haven't rose further than the 60th place. And from the very beginning, we set the task for ourselves, and actually the first PCR system was registered on the 11th of February, and from the 15th of January till the 11th of February 2020, it was just working for the scientific purposes. So we developed all that, and currently, per 1 million of people of testing, we are among the top 10 countries when it comes to the number of testings. And well, usually we just calculate the countries with a population of more than 10,000 people, because of course it's all about different quantity, but we can see that the coverage of testing in the Russian Federation is quite a large one, and the estimated average infected cases in Russia, the coefficient is 5.8, and we are currently at the 79th place among other countries. From the very beginning, we were working jointly with our colleagues from CIS, and upon the request of the President of the Russian Federation, Vladimir Putin, and he requested us to do this from the very beginning, which I mean it was done in the 20s, around 20th January 2020, we had to provide for methodological support of our activities, and we had to provide our colleagues in the Eurasian Economic Unit Council the testing systems. And we also provided the testing systems to our colleagues and the subjects of the Russian Federation. Here you can see the dynamics of the infected cases and the overall number of infected cases per 100,000 people. Well, there is no country in the world that has avoided the threat in the world, or in the CIS, or in the Eurasian Economic Union. So here you can see a brief algorithm of our actions and what we've been doing. First, the monitoring of the situation in China. We started to do this on the 31st of December, when we learned about it from WHO. And here you can see that on the 15th January 2020, our scientific center Vector developed 2 sets of PCR tests for the purposes of diagnostics. And after that, we unveiled our mass production, introduced the methodological recommendations, and up to the beginning of March and up to the middle of March, you can see here that on the 2nd of March, the first infected case was registered in Moscow. And from the 17th of March, we believe that the development of the pandemic in the Russian Federation started. Yes, we did introduce some very strict measures when it comes to the border crossing, and these measures were quite a grounded one, because even today in Russia, we do not see the circulation of the coronavirus that has been brought to us in the first half of the previous year from China.
And again, I want to state that from the very beginning we were speaking, and we are already stating this from this tribune, that the infection has no borders. It is obvious, but we were taking a task for us and are working on the realization of a united epidemiological space on the territory of CIS and of the EIU countries. So here is what we've done. From the very first days from January last year, we were holding the sittings and meetings of the working organ that we have already, and it's fulfilled the obligations. Every week or 2 weeks we had the meetings with interchange of information on the situation, and my colleagues that are now in the presidium, and they were and are remaining the active participants of these sittings and meetings of the board to coordinate our activities. And also within the framework of the CIS Coordination Council on the issues of sanitary protection of the territory was the second instrument that provided for proper coordination of our activities, to share with our colleagues all the methodologies and to accept the best practices from our colleagues. And as a result, in July 2020, we've passed the plan for the complex healthcare and sanitary well-being of citizens of our countries against coronavirus and other diseases within the EIU, and the midterm plan for the cooperative actions of CIAs in combating and counteracting infectious diseases, and then agreement on sanitary well-being. And this document has the supreme power because it is signed by the presidents of the countries, member states, and these documents are now effected. And speaking about the Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, we are stating that we have 23 scientific and research organizations, 17 of them are epidemiological and microbiological institutes, and this is very important for us in this not simple situation, because this structure, this construction has played its invaluable role. Because, why? Because all the events that we were developing and that we were offering and realized, they were based on the scientific base. That means on the basis of scientific data, research, and endless monitoring of everything that is known in the world as of date, and this was used to form our position. And further, to form and build on the management and governing solutions. Here we have the results of the vector. What was first done? We've initiated monitoring of the changes, because the changes of the virus are making a clear picture on the related to the tasks on actualization of PCR systems or on creation of vaccine. And here from the very beginning, as you can see, on the basis of vector, we've started to test the changes and to provide sampling of our system. And by the way, our system is vertically integrated. It provides for best management of the system, and Vector has samples from all the territories of Russian Federation. And what was very important to do from the very first days of the pandemics, we needed to collect biological models. We understood that not mice, not rats, not small animals, mammals can be models, because they are not susceptible to the coronavirus. And we've conducted this particular work, and we've checked the specificity of the new coronavirus to different tests, different chemical substances. 688 chemical substances were tested for their susceptibility or activity towards the new coronavirus. And unfortunately, as you know, the whole world make this, and it is not found in the whole world the chemical binding or binder that would 100% fight the coronavirus or the new virus. What was very important for us? We needed to understand how to fight against this. We needed to understand the specificity of the virus, and here was the framework of our work. And I can remind you, and I'm pretty sure that you can be reminded of this, that the first weeks of January 2020, we were thinking that this virus is not handled from one person to other, that there is another mechanism. But then we understood that it was not the case. And about the environment, our Central Institute for Epidemiological Research and Development Institute is assessing the environmental affection of the virus, and we've facilitated the pilot project. And then in all subjects of Russian Federation, we are performing due control. We are controlling the environment and controlling it for the coronavirus. And as you see, the plan tests are not making virus the evident, but in the cases where we have diseased persons, we have positive findings in more than 3% of the cases. It is also very important to state the fact that we had to develop these test systems to change the properties and structures of these test systems. This was done also by our institutes, Vector and Central Research and Development Institute for Epidemiology. We were working on the basis of polymerase chain reaction. And it was also very important to understand how to define the immunity. And again, I want to remind you of the March 2020, because we were not able to state at a certain time whether it will be immunity or no immunity against this immunity. What are the numbers and digits that will state that this person particularly is under protection? We were working on the basis of IgG, immunoglobulin G, for post-infectious immunity in persons, in patients. And we also solved the task to create express tests for antigen and express tests together with the IFA technology. All these test systems are now used in our laboratories in the Russian Federation. Also, a very important topic that we were not forgetting about, as it was stated from the very beginning of this conference, we were speaking that coronavirus is a very important topic that took many lives, coronavirus per se, but we don't have to forget that the other infections are not gone. They are here, they persist. And as of now, we are speaking that unfortunately, and this was also mentioned in greetings from our colleagues from UNAIDS, for example, in the year 2020, there were more problems in access to antiretrovirus therapy. And now we have to put the task on the urgent overcoming of these issues that are posed by the time being. The today's current situation in terms of infection related to the HIV virus. It is represented on the slide. We see a dynamics, and this dynamics is certain, but for the first time I want to speak that the masses are growing. That means masses of people who are getting their tests. Of course, perhaps with this we see some decrease in the evidencing, but this is a huge task for all who are engaged in the works in the region in combating against the HIV. In Russian Federation, we have for many years a program and we are investing many efforts in realization of a program for help of the countries in combating the HIV infections. We have sustainable professional relations to the international specialists. We have scientifically based rehabilitation programs, preventive programs for children and women in Central Asia. We have the increased control for infectious diseases, express test on the basis of mobile clinics against HIV, and we've supported the not only urban but also all other stations. As of now, we have more than 3.5 million tests for HIV, studied more than 4,800 people, and the information campaigns in 5 countries are covering more than 5.5 million of people, and we have 13 mobile clinics that are working in 4 countries of the program, and they render the services for 2.5 million of people, and there where the medical assistance is not excessive at the time being. So our cooperation project with the FAO, Food and Agriculture Organization of the United Nations, we are testing microorganisms towards the antimicrobe drugs, because I need to remind you that the tactics of treatment of all COVID patients is pretty much the same in the whole countries, and it suggests significant use of many types and many antibiotics per se. And we are staying on the edge here because there is a huge risks in microorganisms that are poorly resistant to the antibiotics, and we are seeing this already now. We are running these works, and to avoid this factor that is affecting NMR with the food intake of antibiotics is very important. And I want to especially thank our colleagues from Armenia, Belarus, Kazakhstan, Kyrgyz Republic, and Tajikistan who are involved in these projects, because it is very important. It will gain in importance more and more. We need to be very precise here. The projects of international medicine and sanitary rules in the Asian countries is held by 18 profile agencies out of 8 countries of the region. They are united in one monitoring system. And as of now, in this year, we faced the first monograph on realization of international medicine and sanitary rules on the Eastern Europe and Central Asia, with participation of specialists from 7 CIS countries. This is a huge amount of work, and this is a very important amount of work, because we need to prevent and block the localization of any infectious initiative statuses that we are dealing with right now. There is a huge task in assessment of population immunity, because we all know that the development of the infection is put on hold when there is a herd immunity, high level of herd immunity, and when we have a growth in immunized people and in shaping of the immune population. To assess this, to assess and understand how and what is happening, we are realizing project on Armenia, Kazakhstan, Belarus, Serbia, and Uzbekistan. We've ran this work in the Russian Federation, and as of now, we are using the experience that we've gained during these pilot projects. We are cooperating with colleagues, with practitioners in different countries to assess collective herd immunity of all populations in different age groups, and to understand the level of serum prevalence in different groups of the population. That will provide for additional planning of the events, to make forecasts, and to understand the necessities in vaccination in defined groups of population. For us to clearly and rightfully to realize our knowledge and practice together with our colleagues, during the last year, we've made a huge amount of norms and regulations. It was not the case before. We were rationally working. This basis is providing for methodical recommendations, and methodical recommendations can be changed along with the situation and along with the new knowledges. All services, agencies render, all services are rendered according to the recommendations that we've made available for all the sectors of economy. In the last summer, we've made it real, and we realized the healthcare company, and from the from the start of this year, we've made it possible for the children to go to school without any outbreaks and without COVID distribution in children and adolescents. We've made it to change in terms of change of the norms and regulations of the legal basis. And here you see the results of our consolidated activities together with the colleagues from different branches, from different levels of executive bodies, of authorities of Russia, to form everything which was stated in the 3 decrees of the president. We have a new law on epidemiological safety. We were forced to work on the administrative and criminal punishment level to make more severe sanctions in these terms, and we've backed up the plan for the development of federal state sanitary and epidemiological surveillance on the territory of Russia. And I also wanted to state the following: for the CIS member states, for monitoring, operative notification and due time of reaction for the sanitary and epidemiological character actions, we have also sanitary basis of the member states in CIS, and through this base we have the possibility to realize our methods, our knowledge, and the tasks are provided as follows. And I want to state that in 2018 we've shaped the united system for CIS to react against epidemiological threats on the series of the base of Institute Microbe in Saratov. We've started 2 programs, and we enhanced the functional of standardized functional informatization systems, and this is very important. We will work on this. This is also a very important problem, because we are working with live people. We are working with the doctors. Not all the doctors were aware and are aware even now how to work in the outbreak parts of country, and we needed to provide for additional trainings for the doctors. And here we see the program for the preparation of and retraining and additional training of our specialists. We have managed to train more than 500 profile specialists from profile agencies and more than 1,000 specialists from other countries, from foreign countries, in terms of sanitary and biological well-being and safety and new technologies in the epidemiologically and laboratory diagnostics. We were working with the teams of rapid reaction in the years 2017, 2018, and we've planned also the study, the similar studies in Kazan in the autumn this year. And I am pretty sure that all the responses to your offers will be realized, and we will be able to make it as a reality. And it's very important that we rendered a significant help to the colleagues and to the people from different countries. We've during the last year we've made more than 20 missions in 16 countries. We were sending test systems. We were working with Guinea, with Vietnam, for example. In Tajikistan, we've enhanced the quantity of laboratories up to 11. We introduced the new recommendations for several countries. We had 10 training seminars, and so on and so forth. And of course, we need to state that we have a united epidemiological space. This is one space. It is united. There are no borders for infection. There are no borders for nature infections, outbreaks from the nature, zoonotic infections. For example, the animals who are the basis for zoonotic infections, they don't know anything about the borders. The herd immunity is shifting, and it is all an important system of our monitoring. And of course, we wanted this work to be done in a more active way, to be realized proactively, to be held on the territory of our member states. And of course, we want to thank the WHO for the support of multilateral mechanism and coordinator of global efforts in the healthcare. I want to thank you for your kind attention, and I want to wish you good luck and success. And I do hope that as of today, we will manage to discuss all the tasks and arrive at great results. Thank you very much. Thank you. And now I want to invite you to listen to the reports of our colleagues that are a part of the plenary sessions. And I want to let the floor to Ms. Shannon Hayder, Deputy Director of UNAIDS. Ms. Hayder is head of the program activity of UNAIDS, and today we've heard very great words related to her, and we want to join to these words. So, Ms. Hayder, the floor is yours.
Great, thank you very much. It's really my privilege to be here with you all today and to join this important conference. Can I get my slides up? Great. Thank you. And not only privileged to be here, but to have already seen in the video and heard from Dr. Popova the real importance of this regional cooperation program. We feel very privileged to be a part of this partnership and look forward to working together for years to come on these important works. Next slide. Or is there a slide controller? Great. So just a little bit of a snapshot of what's happening globally with the HIV epidemic. And as a reminder that as we look past over the last 40 years, we've had over 76 million people infected with HIV and over 33 million people who have died of AIDS. Trying to see. I will get this down, I promise. Great. And when we look at the trends, we have made major progress in the reduction of deaths from AIDS, yet we haven't gone far enough. Treatment expansion over the last 10 years has resulted in dramatic declines. However, we are still, as a globe, missing the 2020 targets for reduction in AIDS death. Because of our not meeting the 2020 targets as a globe for reducing deaths, there'll be an additional 800,000 people who have died of AIDS who wouldn't have if we had all pulled together and achieved the goals. Likewise, new infections from HIV are decreasing, but not fast enough, not everywhere, and not for all people. As you can see at the bottom, we'd hoped to have fewer than 500,000 new infections from AIDS each year by the time we reached 2020. But as a world, we missed that. We had over 1.7 million new infections. And the situation in Eastern Europe and Central Asia is even more critical. In some cases, having increased infections instead of decrease. Cumulatively, for having missed the 2020 targets, we've had 3.5 million additional new infections than we would have if we had all made the 2020 targets. So as we recommit, we have bold new 2025 targets that will get us back on track to end AIDS as a public health threat by 2030. The gaps we've seen represent major inequalities in the response to HIV. Some countries have made tremendous progress, some have worsening epidemics, and every country has specific people or communities still left behind. So the new global AIDS strategy sets targets for the HIV response based on evidence. They capture the evidence-based interventions that, when taken to scale, will lead to a breakthrough in progress to reduce new HIV infections, AIDS deaths, and end stigma and discrimination. And importantly, and you've heard referenced a couple of times today, United Nations member states' commitments have been critical to driving bold progress against AIDS. It was historical when in 2001, the United Nations General Assembly had a special session on HIV/AIDS that had arisen from a historic debate in the UN Security Council on the impact of AIDS. And this UNGAS meeting was the first ever special session on a health issue. It globalized health as a political priority for the world. Since then, our high-level meetings have taken place every 5 years to review progress and to commit to new targets and the next steps to get ahead of the virus. But I want to make 2 points about this new next 5 years that we're looking at right now and the last 5 years of the last political declaration. For the first time in the last 20 years, the 2016 political declaration targets were not achieved. That doesn't mean that the targets weren't realistic. In fact, over 40 countries reached the 90-90-90 treatment targets. The problem remains that progress is uneven, being made in some countries and not others, for some people and not others. And so that's why a frame of the next 5 years from the United Nations Global Strategy on AIDS is to end inequalities so that we can end AIDS. Multiple intersecting inequalities affect people and drive the HIV epidemic. Some people in some places are benefiting greatly from the new science and technologies, services, and other people are not benefiting from that at all. Evidence shows that this next stage of HIV response is no longer one size fits all. It is about making sure those who are most affected by HIV are empowered to minimize their chances of infection and access services that help. And we must recognize that, of course, COVID-19 has increased many of our challenges in the HIV response. Make sure I got back to the right one. We've seen challenges in services and logistics and distributions, but we've also seen a new urgency and an opportunity to adopt ambitious thinking and innovations to fight outbreaks and end pandemics. We've seen innovations for HIV service delivery, even as we've seen some of the inequalities that drive HIV in terms of poverty, education, access grow. And importantly, our collective investments in the AIDS response to date have been truly important to progress against COVID. And we've heard about a couple of those examples here today. The mobile clinics that are part of the Regional Cooperation Program that were great for HIV services and for primary health care have become critical to reaching people on issues of COVID as well. The science, the epidemiology, the vaccine and virologic expertise, clearly we've seen dramatic products of the vector vaccine work that certainly intersects with the work from HIV/AIDS. So it's important for the world to also realize that our investments in the HIV epidemic, in fact, are investments for the global security and the fighting of pandemics writ large. So what are we going to do now? What do we need to look at? Well, certainly combination HIV prevention works, but it's not being taken to scale everywhere and every place. As I mentioned, we're no longer in a one-size-fits-all response for HIV prevention. We do not yet have a single magic solution for HIV. There's not an HIV vaccine. But those still left behind and who are highly affected or at risk for HIV often require more than just one thing to protect them against HIV. Knowledge about HIV and sexual health, yes, but also access to biomedical interventions like condoms, drug treatment, pre-exposure prophylaxis, and access to the societal enablers such as education, income, and protection from violence. To understand how we reach those most affected, most at risk of new HIV infections, we have to really understand who is getting newly infected, not just newly diagnosed. At the bottom of the slide here, you see an example of some work in 2018 that showed amongst new diagnoses in Belarus, Kyrgyzstan, and Tajikistan, over half of those who were being newly diagnosed that were newly infected, not just diagnosed, but newly infected as measured by incidence assays, were women. This makes us ask, okay, what are women going to need to be reached with these more layered and important interventions for HIV prevention. And when we look worldwide, we will only end AIDS as a public health threat by addressing the needs of key populations: men who have sex with men, sex workers, people who inject drugs, prisoners, as over 62% of all new infections worldwide are among key population members and their partners. And in many regions, this is over 95, 96, 97, 98% of all infections. We have seen, when we look at the region, perhaps a stabilization in the number of new cases of HIV, and we look forward to seeing sustained decreases, which is what we really need in terms of new HIV cases and infections. As we look towards 2025, as we look to see where we're starting from 2020, it's really important that we get the most recent and complete data from all of the countries in the world, including in the region, so that we can know collectively where we're starting and where we need to get to reach the SDG target of a 90% reduction in new HIV cases by 2030. And again, some of these bold cascade targets are achievable. This here shows that when we look at the 90-90-90 treatment targets, as I mentioned, we have over 40 countries that, in fact, will have achieved these bold 90-90-90 treatment targets with the 2020 data. These targets, of course, were considered aspirational when they were first put in the strategy, yet over 40 countries will meet them. Here you see that 2 countries have already surpassed the 95-95-95 treatment targets. These are Switzerland and Eswatini. You can't imagine 2 more very different countries, yet both have created their own responses, their own systems, used their data to find the people who need the resources the most, and have covered 95% of their goals. When we look across regions, certainly progress in HIV testing, in treatment, in viral suppression, they vary. Progress is unequal by region, but gaps, the specific gaps, also vary by region, as they vary by country and even within countries. In Eastern Europe and Central Asia, there has been a lot of success in HIV testing. People living with HIV are being diagnosed, but there remains a big gap in those people getting on HIV treatment. At the end of 2019, the cascade in Eastern Europe and Central Asia was 70%, 63%, and 41%. This is another way of looking at the progress in the HIV testing and treatment cascade in Eastern Europe and Central Asia over time. Importantly, I want to direct your attention to the final column to your right there. That's the mid-year data on new diagnoses for HIV. And although HIV testing volumes have been affected by COVID and reduced by COVID, we actually see in that far right gray bar that the number of new diagnoses for HIV have increased compared to other mid-year terms. So somehow the right people are being found, maybe found even more effectively, even as the overall testing has been impacted. When we look at vertical transmission and new infections in children, we again, as a globe, have made great progress since 2010. However, over the last 2 to 3 years, progress has stalled, and we're seeing different reasons for that in different countries based on the state of their programs. In some countries, this is because pregnant women and breastfeeding women are never accessing HIV services at all. In other countries, it's because they're accessing, but then falling out of care or being lost during pregnancies. And then in other countries, some with extremely successful HIV vertical transmission programs, it's not that the women who are HIV positive at the beginning of pregnancy or breastfeeding are falling out of care, but there are women who are being newly infected during pregnancy and breastfeeding who are accounting for the remaining pediatric infections. And I'd point out that women who are members of key populations are oftentimes most at risk of being those women, of not being able to access the combination HIV prevention services they need during pregnancy and breastfeeding. Yet across these services where we have really found power is when communities are at the center of the response. The JIPA principle, greater involvement of people living with HIV, has been an underlying approach that has been critical to governance and decision-making, to the direct delivery of services to people, and for accountability. Community-led monitoring helps ensure that what's been promised by government, by partners, is actually being delivered on the ground. And then finally, and unfortunately, stigma and discrimination against people living with HIV and key populations remain. We are far from the zero discrimination goal. People tend to think of stigma and discrimination as something organic, something that we just have to wait to change. However, there are evidence-based ways to reduce stigma and discrimination, but they need leadership commitment and funding in order to be implemented powerfully and at scale. Apologies for my lack of agility with the clicker. And importantly, when we talk about resource needs, our 2020 projected resource needs were never fully funded. And as we've already talked about, the world did not achieve our HIV goals. As a result of those 2020 goals not being achieved, the price tag has gone up. The global price tag to achieve the 2025 targets is actually higher than it would have been had we achieved the goals so far. It's those 3.5 million new additional HIV infections beyond what the targets would have projected that mean we have a lot more work to do now than had we gotten ahead of the game earlier on. So the new price tag is for lower and middle income countries, we need about $29 billion to reach those 2025 targets. But importantly, this $29 billion, it's not a development assistance goal. It's a total package of money from all sources. Over half of that budget is from upper middle income countries. And so we do expect that domestic resource mobilization will really cover the bulk of those monies. So when we look at these new 2025 targets and the new global AIDS strategy, a few things worth pointing out about the boldness of these targets. First of all is that the service targets, it's not just that they're going from 90 to 95 for treatment, for prevention, but in fact that 95% coverage applies to each highly affected group so that we can eliminate inequalities and minimize those left behind, making sure that those we need to reach are not hidden in the national averages or global averages of success. And then finally, for the first time, these targets include specific, quantifiable, evidence-based targets for social enablers to reduce measures of stigma and discrimination to less than 10%. So when we look at the Secretary General's report from the United Nations on the future issues to be debated and negotiated in for the high-level meeting in 2021, here's the list of topics that we must address in order to make progress. So we hope that everyone from all member states, all your countries, your governments, we hope your experts will help your politicians rally around this important event of the next high-level meeting on AIDS that will happen in June 2021. It'll be a hybrid event, part virtual, part in person, and as you can see, there'll be a number of activities leading up to that event that are very important. Everything from later this week, interactive multi-stakeholder hearing in response for the preparation of the HLM, to the start of formal and informal negotiations on the political declaration, to then the high-level meeting itself, at which point we hope that all member states will again have come together in solidarity, in commitments to bold and important targets, so that we will, in fact, make progress and achieve the results we need to really end HIV as a public health threat. So thank you.
Thank you very much, Madam Hader, for this extensive, very clear report. It was very important for us all to hear. And distinguished colleagues, now we have Jens Lundgren from the University of Copenhagen. He's an infectionist and he has an extensive experience when it comes to the treatment of different infectious diseases, including HIV and AIDS. And at the beginning of the coronavirus infection, he led the full-scale test and study on the medications against the coronavirus 45 once. And today we asked Professor Lundgren to take part in this conference, and he will be speaking about COVID-19 and its effect on HIV and AIDS. So please, Dr. Lundgren, the floor is yours.
Dr. Lundgren, we cannot hear you right now. Your sound is off.
Can you hear me now?
Yes, thank you.
Okay, I think that's...
Да, спасибо, вас слышно и видно очень хорошо.
Yeah, thank you. We can hear you very well.
Okay, very good. So, looking at those two infections, it's striking how many similarities and interactions there is. We know now that HIV-positive persons are at excess risk of COVID-19 disease progression. And equally, we know that HIV care is significantly disrupted by the COVID pandemic. On a biological sense, it's also interesting to observe that the... Excuse me?
We can hear you. It's interpreted simultaneously.
Okay, so if people could put their microphone on mute, that would be helpful so I don't hear that back, please. Thank you. On a biological level, it's also interesting to observe that the risk of the infection depends on the inoculum size. So the larger, excuse me, can somebody please turn off their microphone so I don't hear that in my ear, please? Thank you. Okay. Equally, it's interesting to observe that the development of concepts for prevention and treatment of SARS-CoV-2 currently really at a stage similar to where we were with HIV between 1995 to 1997. You remember this was the time when there was a breakthrough in understanding of how to treat HIV. For SARS-CoV-2, we have drugs of modest activity, and we are starting to learn that combination of these drugs are clearly the way forward. And that was the revelation in HIV as well. Of course, the major difference is that we know that there is a curative immunity correlate for SARS-CoV-2, which have allowed for the development of vaccines, which unfortunately is not identified. The immune system is not able to cure a person from HIV, and therefore, as a consequence, we still don't have a vaccine against HIV. And the likelihood that this will be developed in the near future is pretty slim. So there's evidence to suggest that people with HIV are at excess risk of contracting SARS-CoV-2. I don't think that's surprising. It's probably mainly determined by social determinants. When you're HIV positive, the chance that you're living alone is increased, and therefore you're seeking social contacts more often. It's not possible to maintain a social bubble in your social network, so you have contacts with more people. You may seek sexual contacts with other people, and that explains, I think, that part of it. It's also becoming clear that the mortality, if you're infected with SARS-CoV-2 from COVID-19, are increased in persons who's HIV positive. However, it's also important to emphasize that the HIV factors that is affecting the prognosis really depends on whether you have access to treatment to treat your HIV disease. It looks fairly consistent that for people with HIV who is on effective HIV treatment, they have pretty much the same risk for COVID-19 as people who do not have HIV. In particular, if they have been on HIV treatment for 6 to 12 months. And this obviously puts a major burden on the health system to continue to accelerate the testing for HIV, as well as placing people on HIV treatments, in particular in high prevalence areas of the world, like in Eastern Europe, including Russia. The data suggests that those at increased risk of contracting a more poor outcome from COVID-19 are older adults and people at any age who have serious underlying medical conditions. And of course, we know that the proxies in HIV populations for weakened immune systems are people with low CD4 cell count and people not on effective HIV treatment. So again, this is an important take-home message that again emphasizes the fact that HIV is impairing the immune system, and as a consequence on making the body less able to combat other infections where there is a curative immunological correlate. It probably also means that it is plausible that the protective ability from SARS-CoV-2 vaccination is also reduced in people, HIV positive people with lower CD4 cell count and those not on treatment. Again, two other arguments for why it's important to continue to accelerate HIV testing and placing positive people on treatment to rectify this. There's a number of studies around the world to suggest that HIV care was markedly perturbed during the lockdown. This is an example from a study from South Africa, but I believe I've seen data as well from Russia and Ukraine that mimics this quite clearly, that the number of ART collection visits that was missed, in particular during the most heavy lockdown, was markedly increasing, as well as the testing centers that were set up for screening the population for HIV and getting them into HIV care was also markedly negatively affected. And as a consequence, as has been alluded to by other speakers in this conference, it's quite concerning that in particular in areas of the world, in particular in the Eastern European region, where there's been so much effort being placed into overcoming the HIV burden, that those efforts, at least temporarily, has been set back, which means that we need to focus even more on this as we get into a more normal situation, hopefully soon. We also know that another disease that is heavily affecting HIV positive people in the Eastern European region, namely hepatitis C, that the public health response towards that is also greatly affected. This is a study from another section of the world, but clearly shows that the testing as well as treatment for hepatitis C was greatly reduced during the lockdown period last year. When that is said, there's also some positive signs here because, and I think other speakers have alluded to this already, that there is evidence to suggest that the way that we are providing HIV care in a situation where we are unable to maintain the HIV service structures that was there before COVID-19, that innovation starts to happen. For example, using multi-month dispensing policies for ART as one example, where you can see in this study from Africa that you saw a substantive further interval between people having to get their HIV medicine. Just as an example, here you can see that we are now up to over, around 60–70% are receiving medication interval of 3 months or more. I would have to say in my clinic in Copenhagen, we are now moving to 1 year interval. So there's still some distance to go, but it really shows that the burden on HIV care structures can be reduced because you can dispense medicine in longer intervals. Another important development, I believe, that COVID have learned us is the use of telemedicine, electronic means of communication, as opposed to having the patients necessarily turn up physically at the HIV care structure. Of course, some laboratory test is needed, but again, in many parts of the world, we are now moving to doing laboratory tests every year in people who is in a stable situation, and that also will reduce the burden on HIV care facilities, and something that we can learn from despite the hardships that we have experienced from COVID. Finally, just to give you a few comments on treatment for COVID-19. There's been an enormous effort to try to identify effective medications against this infection, which have develops in different stages, from the early stage where people are typically not in the hospital, and then in some people they develop COVID pneumonia, which then further in some people is accelerating to a hyper-inflammatory state that typically leads to the necessity of admission to intensive care units. The antiviral drug remdesivir has been helpful in stage 2 in those with pulmonary disease, not the more sick people, but in that sort of small window of the disease course where people are admitted to hospital, whereas dexamethasone has really been helpful in the more hyper-inflammatory stage of the disease. There's emerging data that potentially in this setting of patients, the combination of dexamethasone and tocilizumab, an IL-6 inhibitor, may be more helpful, although that's still debated. Importantly as well, in people who is hospitalized, heparin to reduce thrombosis risk has become standard of care in many places. There's an ongoing debate about the dosing of this medication. And then finally, of course, if people are hypoxemic, provision of supplementary oxygen. But that's really the stage, I believe, of where we are with medication. And although I believe many physicians have the desire to give sick people more medication, that really is not really what we should do outside of clinical trials. We should maintain focus on providing medication where there's good evidence. And therefore there's been a lot of speculation last year about whether HIV drugs would be effective against COVID-19, including lopinavir, darunavir, and ritonavir. It's now conclusively that is a null effect, and if anything, it leads to excess harm, and therefore HIV drugs are not effective against COVID-19 or SARS-CoV-2, nor are hydroxychloroquine. Again, if anything, hydroxychloroquine leads to net harm if you're providing it either as prevention or as treatment. There's a number of trials ongoing to explore interferon, favipiravir, ivermectin, as well as convalescent plasma and neutralizing antibodies, and those entities are still to be defined in a research setting and therefore not used outside. So in summary, HIV-positive people with impaired immune function, no or late initiated ART are at excess risk of COVID-19 complications, including excess risk of death. We see as well that COVID-19 have interrupted HIV public health measures on many different fronts. We know now, unfortunately, that there's new SARS-CoV-2 variants that escape the immune protection that the immune system is otherwise able to provide us with, and as a consequence of that, we need to think very innovatively around ways to further boost the immune system so it can also protect us against these new escape variants. medical interventions with documented effect includes dexamethasone in people with severe COVID-19, not in people with less severe disease, really only those in stage 3. The role of tocilizumab, if any, and for that matter, baricitinib, the JAK inhibitor, is to be defined and is still being discussed extensively in the research community. Remdesivir, which have a modest antiviral effect, we call it the oseltamivir-like drug against COVID-19. Oseltamivir is obviously used against influenza. It has its place in patients with moderate COVID-19 pneumonia before they get into the intensive care. It has its niche there. Of course, we need to use supplementary oxygen, where the target saturation in arterial blood should be between 92 and 94%. Don't get them up to 96 to 98%, but that range seems to be where the benefits are most optimal. And then consider using heparin in hospitalized patients. And I just wanted to leave on the note of, again, thanking you for inviting me to this conference. I wish you all the luck in your further deliberation. We have a lot of work in front of us, not only in handling COVID-19, but also to maintain focus on the HIV epidemic in the Eastern European region. And I look forward to continued collaboration with colleagues in Russia, in Ukraine, and many other Eastern European countries, a collaboration we have had for many years that we look forward to continue. Thank you very much for your attention.
Thank you very much, Dr. Lundgren, for your very interesting report, and mainly for your idea and for your eagerness to cooperation and to exchange in operation, because we are speaking together about unity for the benefit of the people around the world. Thank you. And our final presentation on the first plenary session is the presentation of the Director of the European Regional WHO Bureau, Dr. Hans Kluge, and he is not a rare guest in the Russian Federation. He met the head of the government of the Russian Federation, and our cooperation is very valuable for us, and we are really and indeed supporting the actions of the European Bureau of the WHO in terms of consolidation of medical community, political community, to solve the main issue, the main question on how to save our health of our people. And I want to state that Dr. Kluge led the Bureau of the European Bureau of the WHO on the February 2020, and he was the one to face this new coronavirus infectious disease. And I want to thank Dr. Kluge for your great work and for as we can state it and as we can assess it, and for your kindness and for the comfort that is achieved in our cooperation. Mr. Kluge, the floor is yours.
Уважаемая Татьяна Алексеевна,
Distinguished Tatiana Alexeyevna, distinguished Anna Yurievna, distinguished colleagues and the participants of the conference. 2020 opened our eyes to the imperfections of our system, of our healthcare system, as well as the response to the emergencies. The pandemic has confirmed that the old lessons should have been learned, and it taught us some new lessons. COVID-19 unveiled the inequality and underlined the importance of the coverage, and it also confirmed our faith in the fact that the healthcare systems play some significant role when it comes to the protection of our society. The pandemic has clearly demonstrated the gaps and the loopholes in the current world when it comes to the response to the main healthcare challenges, and it resulted into some slow renderings of medical services, and it just made desperate those people who are infected with tuberculosis or HIV. And COVID-19 has also demonstrated the prospects when it comes to the global challenges in the field of healthcare that we committed to deliver on. From the very beginning, WHO focused its attention on rendering the aid to the countries when it comes to the preparation, mobilization of resources, exchange of cutting-edge knowledge, as well as the agreement on the measures. We wanted to minimize the effect of the pandemic, the influence of the pandemic on the public health. But we also do not want to lose the sight of our older foes with some pandemic potential. The experience of global programs in the fight against HIV can show us that the care about the marginalized and most victimized people is the most important task when it comes to the achievement of the third SDG. We see that we will not overcome the COVID-19 until everybody is safe. And it has been clearly stated into the roadmap of WHO on the enforcement of the healthcare systems in the European region. In the European work program, we focus on the goal that nobody should be left behind. When it comes to the work on establishment of equal and fair healthcare systems, we proceed from the experience of the past, and we focus also on the settlement of issues for the tomorrow. And the Pan-European Commission on Healthcare is a good example of that. Pan-European Commission on Healthcare and Sustainable Development. It has been established by myself, and it already issues recommendations on the reconsideration for the future. Our best tools when it comes to the fight against the virus is the solidarity and science, and Russia can offer a lot in this respect. I highly appreciate the leadership role of the Healthcare Ministry of the Russian Federation, and I thank the Federal Service for the Surveillance on Consumer Rights Protection and Human Well-being when it comes to the monitoring of dangerous pathogens. And I applaud the Russian scientists for their amazing developments when it comes to the tools to fight against the pandemic. I'm very thankful to the Russian healthcare system as well as to the bodies of public healthcare for the fact that they are very important partners when it comes to the enforcement of collective potential, and they're ready to respond. The third task of the SDG is to provide for their health and well-being for everybody. And it includes the responsibility to get over the epidemic of HIV, malaria, tuberculosis, and other infectious diseases by 2030. The influence of COVID-19 on the performance of this task can be quite a different one, ambiguous one. So, on the one hand, the pandemic can thwart the progress when it comes to the achievement of the goals in the field of healthcare. But on the other hand, secondly, I believe that in the upcoming future, we will go back to the way of the full coverage by the health services. This is very important, and that we also get back on track when it comes to the achievement of SDGs. And our actions will be more determined also because of the pandemic. That does not leave us any other choice as to be very active here. Thank you very much, and good luck. Thank you, Mr. Kluge, for your amazing, wonderful, and emotional presentation. Thank you for your wonderful Russian. Distinguished colleagues, the program of our first plenary session has been exhausted. And so if there are no objections, then I would like to ask our colleagues to open our break. Alona, do we have any other announcements to make, any comments to make, anything? If you have any, please go ahead. Well, we will start our parallel sessions at 11:30. Now we will have a break, 30 minutes, a bit more, and we'll have a lunch break from 1 p.m. to 1 p.m. 45 minutes. Okay, thank you very much. Good luck with the sessions, and of course, good luck with your lunch. Let us once again congratulate you with this very important, especially against this current backdrop, forum. And currently we have a concurrent session. And during this session, we will be talking about the contemporary opportunities and challenges when it comes to immunizations. Today, a lot has already been said about the fact that the previous year was quite a challenge for everybody, including the immunization programs. There were some challenges indeed in the implementation of that program. For some time, the program was halted. It had to be halted, but in general, judging by the results of the previous year, we can say that we made every effort and we caught up, and by the beginning of 2021, we've gained some quite good results across almost all the manageable infections. We see some good results when it comes to target coverage, and this medium range is about 95% of children in the targeted groups. Across almost all the infections, excluding pneumococcus infection. And during the previous collegial meeting, we've already discussed it. We do see that we have some challenges and problems to face, meaning they concern some immunization programs of the adult people. The major losses we suffered, especially among the immunization of adults. We slowed down the dynamics of the diphtheria immunization. We do have some problems when it comes to polio prevention and immunizations. Especially this is about some specific regions in the Russian Federation. And I believe that other countries have faced the same kinds of situations. And today, we are to discuss these problems. We did experience some positive developments as well. The government of the Russian Federation adopted a strategy on the implementation of immunizations in Russia. The plan how to implement all it was approved, and this plan enshrines the challenges and the problems when it comes to immunizations. It sets up the tasks, and we, in accordance with this plan and the strategy, we plan to address all these issues. Such issues as the improvement of the national calendar of immunizations, the calendar of the epidemiological immunization, such issues as the safety of immunizations as one of the core tasks that we face. It is also about the development of the industrial potential, the development of an improvement of different vaccines production. And one of the core tasks that we face today is the herd immunity against the new or novel coronavirus infection. And before we start our deliberations, I'd like to give the floor to the Coordinator, Program Manager of Vaccine Preventable Diseases and Immunization Division of Health Emergencies and Communicable Diseases, Siddhartha Datta. And we would like to thank our colleagues from the European Office of WHO, as well as the colleagues from the global departments of WHO, for every effort you've made. You did indeed a lot to set up the priorities when it comes to the implementation of immunizations, especially against the backdrop of the pandemic. Our colleagues from WHO have been monitoring very carefully all the efforts of Russia that it has made in terms of immunization. Not only this is about the calendar of just regular vaccination, but also the vaccination against the COVID-19. So the first speaker of this particular session is the Program Manager, Vaccine Preventable Diseases and Immunization Division of the Health Emergencies and Communicable Diseases, Siddhartha Datta. So the floor is yours, please.
Really appreciate that, and good morning from greetings from Copenhagen. Really like to thank the conference organizer for allowing WHO Europe to be part of this discussion today. Let me just share my screen with you all. Thank you. And as we start this discussion, I just wanted to highlight a few of the immunization characteristics in the WHO European region, the challenges, and mostly, actually, I think we should talk about the opportunities, like Madam Chair, you have already outlined. Also like to acknowledge the leadership of Russian Federation, the government, the ministries of health in putting forward the immunization agenda in the WHO European region. We need to start acknowledging what had been the impact of vaccination on the health of the world's people until today. We really want to acknowledge that the vaccine had been promoting health. Mostly it allows as one of the biggest public health program in the world, which has got such an expansive reach. The impact this vaccine has done in the life of the people, the economies of the world, is very much seen and known. We also have seen that this has saved lives and the cost to the health system. I think we can immediately see the impact of the vaccination program. This region has remained polio-free since 2002, and immunization and vaccination programs have played a tremendous role in this regard. We have seen the role that vaccine has played in ensuring that the children of today don't suffer from the vaccine-preventable diseases, the killer ones like the diphtherias, like the pertussis. And we just cannot forget the role of this vaccination in preventing pneumococcal pneumonias and others. So I think we need to celebrate, we need to accolade the efforts made by each and every healthcare professional in our region to ensure that the benefits of this vaccine reaches to the people's arm. When we talk about an universal reach of the immunization program, we know that these are the components around it. Just by having the vaccine alone in the country will not ensure that the benefits reaches everyone. It's extremely important that all these elements, the supply cold chain, the organization and planning, supervision of the program so that the potent vaccines reaches to the people, ensuring there is a monitoring and evaluation system, the financial sustainability of through the domestic funding resources. There is a system to communicate these effects of the vaccine, the benefits of the vaccines to the people, and also ensuring there is a robust training and capacity building activities in the country. We should assume that all these elements are sort of running a well-functioning apparatus. Each of these elements need to run in tandem in a coherent manner so that the impact of the immunization program is seen. If we look into the vaccination coverage of the WHO European region, and I'm taking here the measles first dose as an indicator, the WHO European region, the countries have made so important effort, and you can see the top line of the vaccination coverage. It shows that over years, the vaccination coverage has been around 93–94% coverage. It also shows that the population in the WHO European region are willing to receive this vaccine. But also the efforts made by the government can be extremely importantly visible. But while we talk about a very high immunization coverage, We also see a different pattern in the disease reporting in the WHO European region. As you see in the last 10 years, this is before the COVID times, the number of cases of measles reported in the region has also increased. So the coverage is also increasing over years, which has led from 93% in 2010 to 96% in 2019. The number of cases have also increased. So I think this indicates that we need to just look into, within the national territories, within the subnational areas, to see where we can ensure that the vaccination coverage is equitable and also reaches to every community. One of the important things that the measles cases in the recent years have told us that the fragility in the success, we have succeeded pretty much, but the success is also fragile if we don't keep our guards on. As you see here, the cases of measles reported in 2018 and 2019, there was a huge outbreak in almost all countries in our region. This provides an opportunity for us to look at the subnational areas moving forward and finding out the drivers and barriers of the vaccination. So that is where the routine immunization program was built around. Let us try to see what are the reasons behind these inequities, which is actually more important than just looking into the numbers. We have seen that the middle-income countries of our region are lagging behind in providing the benefits of the vaccine to its population. If you look into the number of vaccines, the newer vaccines introduced in our middle-income countries vis-a-vis the higher-income countries, there is a disparity which is extremely visible. We have also seen vaccine stockouts in different regions, different countries in our region, and that in itself provides a barrier to providing access to the vaccination program. The vaccine hesitancy and decreasing demand in some of the vaccines in particular has led to this lower vaccination coverage or underserved areas in our different subnational areas, leading up to these pockets of vulnerable people and an outbreak that we have seen in 2018, 2019 for measles. I think COVID-19 provides us an opportunity. We should see the investments that will be needed to be done by all the member states in our region, and the amount of investment they are doing should be seen as a cornerstone, as a platform for improving the routine immunization of tomorrow. When we start talking about the COVID-19 vaccination and deployment, we need to find out what are the mechanisms that we have now in order to build upon that for the routine immunization of tomorrow. The WHO European region, along with the different partners and the European Technical Group of Experts, outlined late last year the impetus areas which need to be strengthened by each and every country to ensure that the robustness in preparedness of the countries. I think the vaccination program is as good as its preparedness level. And we just wanted to highlight here as well, given that newer vaccines, COVID-19 vaccines are made available, we also need to be flexible in our national immunization strategy for COVID-19, that all these parameters need to be reviewed regularly by the Ministries of Health and by the National Immunization Technical Advisory Groups, so that the agility in ensuring the service delivery happens in the country. What we also need to do is to monitor the reported preparedness status. As you see in the slide, the efforts made by the 53 member states of our WHO European region in ensuring that all these different impetus areas are targeted, they are reviewed, and then a progress made by the countries. As you would see, this is not an uniform picture. Some of the areas, they are far ahead. Some of the areas, they are catching up, which is normal in these circumstances. When we are learning more about a vaccine every day, we are learning how to deliver these vaccines to our communities. And if we start to look into the status of COVID-19 deployment and vaccination in our region, we have seen all 54 member states and territories have started the COVID-19 vaccination. It's quite a remarkable thing to see that everybody, every government, every ministries of health are ensuring that these vaccines reach to the community. As of date, as we see, more than 188 million doses of COVID-19 vaccinations had been administered in the region, with around 14% of the total population of our region at least have got 1 doses. But I think we should not just remain at the regional level to see what has been the status of vaccination. If we go down a bit into the countries by income level, it is extremely visible to all of us that the inequity in COVID-19 vaccine deployment is evident. The high-income countries are far ahead than the lower and lower middle-income countries in terms of their uptake. It's an opportune moment for all of us to come together to see that this inequity in vaccination uptake needs to be addressed, and trying to again find out what has been the drivers and barriers, building upon what we have learned in our routine immunization program in the past. The future looks bright for all of us. There are opportunities for us to build upon the COVID-19 lessons learned that we are learning every day on what needs to be done. The European Immunization Agenda, which is one of the flagships of the European program of work, provides us that opportunity. Building a better health tomorrow should be built on stronger immunization program of today. The 3 different principles that are outlined in the European Immunization Agenda 2030, which is now being developed with contributions and the leadership of the member states of the WHO European region, is to ensure equity in immunization. This is one of the principles which will now then need to be translated into action. The other platform is to ensure immunization across life course. The COVID-19 is allowing us that opportunity to ensure that the modalities of vaccine delivery are available so that countries can deliver the vaccine to all the age group. And obviously the last and the not least one, but most important one, that we cannot have one size fits all. The local solutions in each and every country, in each and every community, would need a local solution. And that is where zeroing down to the community level is extremely important. All of these elements are an integral part of the COVID-19 vaccine deployment. So when we talk about the immunization of tomorrow, as I said, this should be built up on the lessons learned on COVID-19. We know the impetus areas of the National Vaccine Deployment Plan, the 10 strategic areas which each and every member state has invested onto. These lessons should not be just in the paper, and they are translating into concrete actions in the country. These all need to be then intertwined with the principles of the European Immunization Agenda that I have mentioned. But the most important, another element about the COVID-19 global response efforts had been the access to COVID-19 tools, accelerator. The investment being done in the research and development should not go into waste with COVID-19. This should be the platform for us to move into routine immunization, better delivery, better research coming forward. The efforts made by the global community on manufacturing and developing a new vaccine should also be a cornerstone for us to move forward into the routine immunization. The deployment, the service delivery modality in the countries should also be a lessons learned how to strengthen the information system, the health vaccine safety monitoring, the vaccination data and information management. These are some of the critical elements that we are being seen as the priority areas for National COVID-19 Vaccine Deployment Plan. So just wanted to highlight that these all elements, the access to COVID-19 tool accelerator, the impetus areas of the National Vaccine Deployment Plan, and principles of immunization agenda are all seen as one capsule and not a separate entity. So we just wanted to share you some of the resources that, that you may go and look to, but also we'd like to really thank again for inviting us to share some of the elements with you. I pass it back to you, Madam Chair. Thank you so much.
Thank you so much, Mr. Datta, because for the next time you are representing the main guiding principles for the European region countries in realization of national immunization programs, and I really hope that everything that we are doing is really in line and well aligned with those principles. And generally speaking, I want to thank the WHO, the European Regional Bureau at the WHO, for your kind support that is rendered in our work in realization of the immunization program. Thank you very much again. And the next speaker will be Namazova Baranova Leila Simurovna, who is the Academy Midgley at the Russian Academy of Sciences, head of the Executive Committee of the Union of Pediatricians of Russia. She is now in the remote mode joining us, and Leila, I hope you could make it through the online. Yes, hello, greetings, distinguished colleagues. I hope you can hear me right now. Yes, we can hear you. Greetings. Greetings. Distinguished colleagues, at first I wanted to thank Albina Andreevna and the head of the Rospotrebnadzor, Russian Federal Service for Surveillance and Customer Rights. In my short presentation, I want to speak about some lessons learned about the existence of today's and about our future. We live in a very interesting time. It's a great time to live. But I, as a pediatrician, am a bit sad because of the fact that the population represented by children is decreasing. The population of children is decreasing. There are less children right now. This process is well aligned with the fact that there are more and more people living longer than 60 years of age. We see that the percentage of this category of people is ever growing, but unfortunately there are less and less children living on the planet Earth. And of course this is putting us in a framework in which we need to pay special attention to the healthcare services rendered to children. In our country there are 22% of population, so children. By the way, in the USA, in the China, there are pretty the same numbers of population representing children, 22%. We are living in the age of paradigm of programming of health, and these are this 1,000 days program, 9 months of in uterus life and 2 additional years of postpartum. But is this window of programming a bit narrow? I would state it like this, because we are opening this 6 months before the inception, or 12 months, or even 24 months before inception. Therefore, intake of folic acid 6 months before planned pregnancy is helping to prevent the central nervous system diseases in children, compared to the status when we start intake of folic acid from the first days after inception. It is the window that is brightly opened until the end of the childhood period, which is ending not at the age of 18, but at the age of 21, 22 years, because children are still growing after the age of 18. I think that the picture of malignant tumors is showing pretty much the same picture here. If the first class of the diseases is programmed in uterus, it was programmed within the mother's body, the morbidity rate is not high at the very beginning of the age, and from the age of entering the school, we have the decrease of the affection of certain genes with increase of epigenetical factors that are resulting in severe chronic pathology. By the way, if we speak about in uterus development, we need to state that the child in uterus is also the next generation, because within the in uterus child we have a reproductive system organs of future children to be born. But if we want to prevent certain diseases, of course we have arrived at great success at the tertiary prevention, at the secondary prevention, when we are providing for prevention of more acute manifestations of asthma in static dermatitis patients. But of course the primary prevention and vaccination is a genius way to provide for a primary prevention. And I wanted to speak about in uterus state of health and healthy affairs of a child in the secondary in the secondary generation, when, for example, asthma or some consequences of smoking are transcended further to the next generation. Ecology plays also a huge role. If a family lives not far from a chemical manufacturing plant, this can really affect the child. But Th2 type of immune response and pro-allergic response type is inherent to all children, which is supporting the child in uterus, in the mother's body. And at the same time, the Th1 type immunity is not developed, because if it will be very or too much active, it will result in the loss of a fetus. If at the point of postpartum this type of immune response will not be switched, this will be the case of severe allergic or autoimmune or oncological manifestations a bit later as years will go by. But what shall be done to make this switch happen? It is very important for a child to give to have a natural birth path through the birth path of the mother, and during the next 30 minutes the child should have a breastfeeding procedure, so it should be breastfed by the mother. This is the initiator of a switch. And vaccination during the first hours after postpartum is also a type of a normal regular immune response with a greatly developed Th1 type of immune response, and the child will stay healthier for longer. And vaccination together with the breast milk is supporting our children here. What are the lessons learned from the yesteryears? As we know, as Mr. Osler told, the humanity had every time three main foes: the flu, the absence of food, and military atrocities. And this is actually the history for us, because when we take a closer look at the history of Russia, Catherine the Great, together with her son Paul, had the first vaccination before the vaccination was broadly represented in the masses. And although at this time there was a special medal issued showing the necessity of these procedures, and Catherine the Great in Russia told that it is just a mistake for a French a French king to die because of smallpox. This was not the case for the Russian Empire, and until the end of 19th century and at the beginning of 20th century, colossal masses of children in traditional agrar lifestyle of Russia died because of infections. And from the very beginning of its story, the young Soviet Republic, Soviet Union passed a set of decrets the decrees on there was also one special decree on the smallpox and on obligatory vaccination against smallpox. And here we see that from the very beginning the Soviet Union was paying huge attention to the immunization, and the official immunization calendar started to work or to be implemented from 1953, and for this for the time being, about 60 years, you see that our calendar of immunization was changed once in 10 years. There were some new positions, and out of the old one, after we have managed to combat the smallpox in the 80s, we could outline it and cross it out of the list. And we see that there is a huge rise in the life expectancy, plus 25 or plus 30 years even. We see the decrease in many infections. And today, many people just don't understand and don't know how high was the time and how high was the toll that was paid to the infectious diseases in our country, and the toll can be more if we will not work further on the prevention. So, what about today? When we speak about today, unfortunately, our immunization calendar is rather modest if it will compare it to the immunization calendars of the other countries. And when we speak about the routine immunization calendar of the WHO, we see that HIV, Haemophilus influenza type B, is made only for the risk. We don't have rotavirus, papillomavirus vaccination in our calendar, and we don't have the revaccination for school kids in certain cases. And speaking about hepatitis B, in the new edition of the immunization calendar, it will be fixed. Speaking about rotavirus, we are working on the basis of different regions, and we hope that we will solve it and resolve it as a part of the new national calendar for vaccination. And of course, there is also too much work to be done. There's so much work to be done. If we will speak about YLD, in children, take into account 18 most often reasons. As you see, the colors green, yellow, or greenish or yellowish. These parts are speaking about YLD, so infections-related YLD, and this, as you can see, during the last 1.5 years, unfortunately, pandemics can encompass the whole planet, Earth, and together with other effects of pandemics, we've seen the effect as the decrease of access to the routine vaccination that encompassed all the regions, also the European region. We need to state that from the very beginning of pandemics, our professional association published on all possible resources our position document related to the pandemics that we have to provide for the further implementation of planned immunizations. It was also a set of recommendations and methods for the doctors to work with the patients, young patients with COVID in the second edition. What do I want to state here? Yes, we arrived at good results in decrease of child mortality, and in Russia we have a lesser level of child mortality even compared to the USA. But of course the situation can be drastically changed if we will put on hold the planned program for immunization. And as you see, there are also not the best one scenarios and worst case scenarios that can be a real life, and it can be a real case when we will avoid vaccination. By the way, people were thinking in the recent years that we need to fight more with the diabetes epidemics, metabolic syndrome, increased BMI, and oncology. But the last pandemics has shown us really that the new infections, outbreaks of all the vaccine-controlled infections because of the anti-vaccine resistance of the population, resistance features, COVIDs, later death due to COVID, due to thrombosis, due to pulmonary diseases, due to other diseases, have shown that we've missed something here, and we need to be more precise here in this work, because the concept of life lifelong immunization is not a part of our day-to-day life. And moreover, we have a huge problem because of the anti-vaccines movement within the population. And in the beginning of the pandemics, the medical officials and doctors are using official resources. The regular people are unfortunately using only social networks where there are some paid discrediting vaccinations, the ADs against vaccinations with the similar topics, with the similar texts are paid by someone who wants the population, especially or including the population of Russia, not to have the preventive possibilities and not to use the immunization tools. Therefore, the social networks started to show this content as the harmful. You know, there is a long history of some situations related to the vaccinations. Yes, we have in Russia anti-vaccine prone people and groups of population. These are the results of a research in 2016, and you see that the Russia is not showing the best results here in the proneness of people to the vaccination, because people are not believing in the necessity of vaccines, especially in the necessity of vaccines for the children. Of course, we are not in the severe case as the France, but still we see a huge anti-vaccine movement right now. For a certain moment, we've seen that there was a betterment in the year 2018, but in the last summer, we've seen many people who are more prone against vaccines. And by the way, the last work of the group of the effective healthcare working group that was announced in the Russian news agency by the RENEPA, they are stating pretty much the same. We've made a small research of about 2,000 children in different regions, and you see that the picture of immunization is very different. For example, against tuberculosis, against hepatitis and measles is taking a good position, but speaking about the flu, there are almost no people who've got the immunization against flu, according to the calendar, and also pneumococcal situation is the same. By the way, anonymous questionnaire is distributed by the doctor. In the doctors are not showing the readiness of the doctors to be prepared for the vaccine. So, of course,
Now we do understand that the main resources of our healthcare system are for those people who are not curable at all, just to prolong their life. But instead, we should invest more in the prevention. So we, pediatricians, will definitely recommend to do the vaccination. The parents and adults of any age should be prone to vaccination, and any information is always published in our social networks and also on our website of the Union of the Pediatrician of the Russian Federation. Thank you very much for your attention, and once again I'm very thankful for this invitation. Yes, thank you very much, Leila Simurovna, for your wonderful, extensive and historical presentation. I hope that it's not the last time that you present to us, and it would be a great pleasure for us to listen to your opinion that is especially valuable for us. Dear colleagues, now we proceed to our next report by Irina Mikhaeva, professor, PhD in medicine, the head of the Laboratory of Immunoprevention, Central Research Institute of Epidemiology of Rospotrebnadzor. Yes, thank you very much for giving me the floor, and thank you for inviting me to speak at this high-level conference, international one. Today, a lot has been already said by the representative of the Federal Council on the immunization, that it is the baseline to fight for the health of our people. And the previous speaker told us about the immune prevention when it comes to medical aspects, but I would like to talk more about the strategic priorities for the prevention up to 2035. In August, the Assembly adopted the decision that approved the new global program when it comes to the immunization to the period up to 2030. The main element is the immunization as one of the integral elements of a healthcare system as a whole. And here we can see a very tense connection between SDGs of the UN member countries and the immunization program. And the role of the immunization has been demonstrated when it comes to the achievement of 14 out of 17 SDGs. When it comes to the preventive vaccination, we need to implement some national strategies. In Russia, we've been doing vaccination and we had special program from 1998 until 2005. After that, the document was over and we had some other programs when it comes to healthcare. For example, we had a program on the prevention of socially significant diseases. We also had some strategies, etc. And the WHO program of vaccination up to 2035, especially against the backdrop of the current pandemic, accelerated the development of the immunization in Russia up to 2035. And we've developed and drafted the strategy, and it was approved by the government of the Russian Federation in September 2020. Its main goal, the main goal of the strategy, is to prevent, limit the distribution and the liquidation of infectious and other diseases that could be prevented through the sustainable prevention of infectious diseases with the provision of immunobiological medicines that are produced in Russia. And when it comes to the vaccine preventive measures, we see that the Russian strategy is quite concurrent with the international one. And the main principle in here, when it comes to the global and national strategy of the immunization, is the access to the vaccination of the population, as well as the devotion for the vaccination. And it can be provided by the awareness campaigns and the information delivered to the population. Of course, we should confirm, or we should respect the principle of equality. Here we also have the support for the scientific research, as well as the reliability and stability of provisions due to the development of manufacturing of high quality and efficient immunobiological medicines. The 6 priority elements of the immunization in Russia have been developed up to 2035. So the first element of this, it has already been mentioned, this is the redevelopment of a national preventive or immunization calendar. And here we should proceed from a science-based medicine. So we should enhance the number of diseases, then we should target the population groups that should be vaccinated. Also, we should introduce some changes to the calendar when it comes to the immunization of all children of different ages with the combined vaccines with an inactive polio component. We also should develop the full cycle production of vaccines on the territory of Russia in those volumes that are necessary for the immunization. And we also should provide financially the procurement of vaccines against the rotavirus, the smallpox, the human papillomavirus, and other different viruses. What we plan to do as well is to enhance the number of infectious diseases against which we should vaccinate, proceeding from the epidemiological situation. And we should also identify the target groups for this. In respect of the strategy of WHO for the lifelong vaccination, we should also develop the programs of vaccination of separate groups of population to enhance their quality of life. These people are such groups as pregnant women, the people with chronic diseases, the old people, those who can serve in the military services, and some other different groups. And we can also vaccinate children with the multi-component vaccines, and we can also proceed with the vaccines with the maximum volume of serotypes. We can also combine we can replace the 3-valent vaccines against the flu with the 4-valent vaccines. And we can also draft the proposal on the revaccination against the pertussis of people or children of different age. We can also enhance the groups of people that should be vaccinated against the hepatitis A. We can draft the proposal on the vaccination against the pneumococcus infection, and we can enhance this against the backdrop of the immunization calendar. And we can also assess from the economical and social point of view, and if needed, we can enhance the calendar. The strategy also enshrines the profile study when it comes to the efficiency and safety of vaccines against the novel coronavirus infection. Such elements are included as post-registration clinical trials. Also, the study of post-functional immunity to develop the vaccination strategy and tactics, and to include the vaccination against coronavirus to the national calendar of national immunization, as well as to calendar proceeding from the epidemiological situation. And the second element of the strategy is about the improvement of government policy, as well as the system of state control and surveillance, as well as the regulatory framework when it comes to immunization. Meaning we should provide with the harmonization of the legislation in Russia when it comes to the circulation of medicines, and we should make it correspondent with all the acts of the Eurasian Economic Union. We should also be guided by the regulatory acts when it comes to different requests connected to immunization. We should also improve the statistical data and operations when it comes to the prevention. We should also produce an information system and databases on the preventive vaccination. And we should also monitor the immunostructure of different groups of people. We should also check against the herd immunity against the infections that can be prevented with the vaccination. We can also monitor the spread of the pathogens of infectious diseases and their serotypes to manage the tools of the specific prevention. We can also improve, or we should also improve, the legislation of Russia to create a bank and a unified register that will be used for the production of vaccines. And that's how we'll provide our manufacturers with the types of those that are relevant. We can also proceed with a full-time cycle of production of the national vaccines. We can improve the measures of support of the national production of the combined 5 or 6 component vaccines, as well as vaccines that are planned to be included into the national calendar, such as against the rotavirus, the German measles, pneumococcal infections, and HPV. And on the foundation of the Russian manufacturing side, so we should develop the standards that will be adopted by the WHO, and will develop the antigens and antibodies for the vaccines of the flu, the seasonal flu and influenza, and also we will do it for the preclinical trials or pre-manufacturing trials for the medications, taking into account the requirements of EU. And we also should create some databases of the immunoactive vaccination medicines, and we should also prevent outbreaks of infectious diseases that could be brought to the territory of the Russian Federation. We also will develop a comprehensive program on the appearance and development of the vaccines of the new generation for those viruses that do not have any vaccine against. And we should also check and measure the post-vaccinal immunity, depending, of course, on the age and the health of the people that should be vaccinated. We should also improve the personalized approach when it comes to the immunocompromised people. We will also develop the contemporary, based on genetic technologies, the universal methodological platform to develop the efficient and safe vaccines against the viruses of high variability. And the third element of the strategy, which is also a priority, is about the development of the Russian manufacturing sites that will produce the immunobiological medicines, proceeding from the full cycle production. And it will include the modernization of the production sites, taking into account the requirements of EU, improvement of the technologies of the production, proceeding from the current and contemporary biotechnologies, as well as the development of innovative technologies and the design of the vaccines. Also, on the baseline of the Russian scientific universities and institutes that could develop and scale up the vaccines that will be produced afterwards. And the fourth element of the strategy is about the improvement of technologies to provide for the safe immunization and systematic monitoring of side effects after the immunization. And the optimization is also included into that. We should, of course, equip everything with the cooling equipment to observe the temperature regime. Also, we will produce the national thermal indicators. We should also create the medical instruments to be safe, and we should introduce the safe ways of the disposal after the immunization. We will also improve the system of the pharmaceutical surveillance, taking into account the EU requirements, and we will also consider the creation of database that will include all the data on the pharmaceutical surveillance. It will also be presented in English. And we should also monitor what are the side effects and what are the causes of them after the immunization. We should also develop the network of state labs to provide for independent studies of the an assessment of quality of the vaccines. We should improve the sustainability of the vaccines and resistance of the vaccines to the temperature. We should also inform our population. We should raise the level of our medical staff. We plan to develop a whole set of communicative events when it comes to the immunization. We will develop the set to improve and raise the social responsibility of parents in cases they do not want to vaccinate their children just for no reason. We should also develop the loyalty of our population towards the vaccination. We plan to create special interactive modules on the issues of immunization for different types of medical staff, and we want to provide them with the opportunities to study with the use of the portal of a lifelong medical and pharmaceutical education. And we also assessed the status of immunization in Russia. And in 2002, the Russian Federation got the certificate from WHO on the liquidation of polio. And since 2017, the Russian Federation has been recognized as the territory that is free from the endemic rubeole. And by the beginning of 2020, we managed to decrease the number of the hepatitis cases by 15 times, and diphtheria cases are registered at a quite low level. When it comes to rubeole and other diseases, we see that this trend is downward one, and all this was preserved in 2020. Within the immunization calendar, proceeding from the epidemiological situation, we vaccinate against 23 infectious diseases, syphilitis, plague, anthrax, the fever, the yellow fever, cholera, the typhus, and the A hepatitis, and others, of course. And the finance are coming from the regional budgets for this. And as compared to other countries, Russia vaccinates much more than other countries when it comes to the epidemiological situation. Over the last 5 years, the vaccination, because of the epidemiological situation, vaccinated more than 20 million people, and it is quite a good result. As a result of this strategy's implementation, we hope to satisfy the demand from the population, taking into account the recommended coverage within our national calendar. We will also organize a full cycle manufacturing vaccine in Russia to provide for the vaccination within the framework of the national calendar. The decrease of mortality because of the infectious and other diseases is expected. We want to increase the loyalty to immunization, and we want to decrease the number of ungrounded refusals of the vaccination. And we also develop the target indicators when it comes to immunization, which are the diphtheria morbidity should be not less than 0.0 per 100,000 people. Smallpox should be 0.1 per 100,000 people, and the rubella should be not more than 1 per 100,000 people. And when it comes to smallpox and rubella, it should all be not more than 25%. And when it comes to influenza, we want to have 60% of immunization against it. And the share of immunobiological medication that are included into the national calendar of prevention, proceeding from the epidemiological situation, that are produced on the full cycle Russian manufacturing for 2025, 2035, we plan to have a coverage of 100%. So it will mean that Russia will be absolutely independent from foreign provisions of vaccines. Thank you very much for your attention. Thank you, distinguished Irina Viktorovna. This report highlighted quite in a detailed manner the strategic document that was adopted last year on our strategy of immunization, and we are very thankful to you for this. Our next speaker is Arek Artemovich Totulan, the Doctor of Medical Sciences, Director, the St. Petersburg Research Institute of Epidemiology and Microbiology, named after Pasteur.
Thank you, Albina Andreevna, distinguished colleagues. In my report, I want to speak... Yes, thank you. In my report, I want to speak about immunocompromised people. Now I will share my presentation. Yes. Thank you, Irina Viktorovna. So my task is now coped by the Lilia Simurovna, by the previous speaker, and therefore I will skip the immunization calendar, and I want to go straight forward to the problem of immune compromised or immune deficient people. At first, this is the primary immune deficiency, and here, distinguished colleagues, I want to remind you just on the principal groups and homological defects. Now we have the modern contemporary classification, and I was afraid to show it on the slides because these are more 350 nosologies as of today. They are updated. And of course, there is also the set of clinical markers of immune insufficiency or immune compromised states, the primary immune deficiencies. And out of this slide, you may see that if the allergic, autoimmune, oncological manifestations at the first primary immune deficiencies are just the shares of percent, like 1.5 dozens, but infections are the case for the all variants of primary immune deficiencies, which is very topical for us. The secondary immune deficiencies in the clinical manifestations, they are pretty much the same with the primary one, and further on everything is relating to the detailed laboratory work. But let us see that the clinical manifestations they are also on one of the first places, like infectious manifestations of the secondary immune deficiencies. At the secondary immune deficiencies, what is very important for us not to forget about? At first, and let me refer to the article of Azar and Ballas from 2007, I am speaking being oriented on the professional and non-professional listeners. If you will go to the laboratory and let the test of the assessment of immune status and then compare it to the norm values, please do not arrive at the final conclusion like, oh, I have immune deficiency and everything is bad for me, because the first wish that these patients have is just to buy a white blanket and try to go in the direction of the graveyard. But please do not be afraid of this. This is a mistake. I am now referring to the patients and to the laboratories, because not laboratory has a right to understand or to decipher the immunogram, because this is the way of work of clinical immunologists. But when we speak about secondary immune deficiencies, it is very important to remind you, and this is in red, that this is very rare, very often infections, very severe infections, as an infectious sign, very long term of infections, very unknown complications and pathogens. The pathogens that are not typical for the normal immune system. At the immune deficiency, these abnormal pathogens are working harder. What are the mechanisms? I beg your pardon for overloading of this slide, and because we need to be efficient in our time to be within the agenda. But the essence of this slide is as follows. Almost all microorganisms, I'm speaking here about bacteria and viruses, they, in the process of evolutions, they have the mechanisms of how to avoid the immune system. Therefore, on one hand, they can avoid the immune system of a human being, and on the other hand, they've managed to create mechanisms for counteracting the immune system, and here they are severely affecting the immune system in this way. And more, the microorganisms, what are they doing with our immune system? We also learned how to cope with the microorganisms on the level of our immune system, and you can read it out on my slide, because our today's life, current life, and the life of our patient that are getting their biology therapy, the so-called biology therapy with the monoclonal antibodies. This is just a modern set of biotechnological products that are aimed in the first line on blocking on a certain cytokine or cutting out or switching off from the immune system of a certain group of cells. And this is also a serious effect on the immune system. And although the cytokine network as of now, cytokine mesh, includes several hundreds of different molecules, it turns to be that the cutting out of one molecule out of this mesh can lead and can result in serious immune deficiency states. And here, as you can see on this slide, this is seen in view or on the background of drugs without which we cannot imagine therapy of oncological diseases, autoimmune diseases, in a lesser way, but still topical therapy of allergic diseases. And here on this slide, you see the list of main drugs aimed against the factor of necrosis tumors. There are different variants of these drugs. Mechanism of their effect is of a similar type, but the drugs are not similar because they are having different efficiency, different rate of clinical efficiency. and their action or the effect of these drugs in the first line is related to the therapy of autoimmune diseases, exclusion of the necrosis, tumors factors, and as the practice has shown, when the drugs started to be widely used, we have seen that the exclusion of only one molecule is leading to the fact that the latent tuberculosis infection is shifting to an active phase. And why are these things happening? On this slide and on the two next slides, you will see this, that the immune suppressive drugs, they have the different aims and different goals on different stages of the development of immune response. They are acting on the step of differentiation and proliferation of T cells. They can be also active on the stage of transfer of the information about antigen from the antigen presenting cell to the T cell, and they can also be efficient and act and have as an aim, as it is stated on this slide, on the cooperation between T and B cells, lymphocytes, on their effect on plasmatic cells and the complement system. Therefore, we, as of today, have clear understanding that the use of these drugs is leading to the immune suppression, and there is also the violation of immune vigilance. As the result, we see the infection. It can be also oncological disease, autoimmune disease, allergies, and my words, I'm now using these words and speaking about this not to put harm or not to tell the patients to be afraid. Please do not be afraid. I'm speaking to the patients. I'm speaking to the clinicians, clinical colleagues who have no sufficient experience in using of these drugs. Without these drugs, it is impossible, but you have to use these drugs in a very careful way. And of course, we arrive at a question. So, okay, all these groups of immune-compromised patients, are they able to use the vaccine? This is just a hilarious, joyful picture that I took from my colleagues, immunologists, and this slide shows that as of today, there are no absolute counterindications to vaccination. There are no such people who should not get vaccines. When we previously stated that primary immune deficiency that you need to avoid vaccination, no, that is not the case. In the blue tile, you can see here that there are certain indications for certain categories of patients and related to the certain vaccines, of course. And here are certain examples. At first, for example, non-life vaccine, they are safe and they are obligatory at all variants of primary immune deficiencies. And this is just a thesis that I want you to take as the take-home message, and please regard this as an axiomatic statement, because as of today you don't have to provide any special proofs to this. Speaking about live vaccines, the majority of live vaccines are having counterindications. For example, we have the nosologies or groups of diseases in the case of which live vaccines are not to be prescribed or administered. But still, this is not a silver bullet here, because out of this rule there are certain exclusions, and you need to be aware of these exclusions. For example, here on this slide, I will not read it out for the purpose of me sticking to the agenda. But the last but not least nuance that I want to put an accent on, when we speak about immune-compromised patients, we need to remember about the other people who are working or living with them, like medical staff, relatives, neighbors, and so on. We can also speak about the stationary settings, and these people have to be vaccinated, obligatory, because the immunization for them is obligatory. For these people who are surrounding immune-compromised persons, we need to administer immunization vaccines, and in some situations, in some cases, it is unfortunately impossible, and it's a pity, really. Why it is very important? Because we were speaking today about anti-vaccine lobby that is playing its role, of course, but this anti-vaccine lobby is using this particular topic. Like, for example, we have a severe life, the circumstances are severe, there are no people with normal, regular immune system in the modern world, therefore there is this crooked logic that because the majority has some immunology problems or shifts, vaccination is should not be done. No, this is not the case. Of course, these shifts in immunological shifts, there are not negative shifts, or they are not leading to some severe losses in health, as I stated at the very beginning of my presentation, firstly. And secondly, without protection, the majority of immune-compromised people are more susceptible to the infection. And I was deliberately not speaking about COVID-19 until this last slide, because what do we see? We are oversaturated with this topic. We are speaking too much about COVID, and if everybody will speak about COVID-19, at the end of the day, we will just forget about this problem, because this is a problem, and we don't need to forget about COVID. Therefore, the last slide is devoted to this fiery, burning topic. Why? Because, as population research states and shows, and I mean the population research made by the Federal Service of Surveillance and Consumer Rights Protection and Human Well-being in 26 regions of Russia, and in this program we see participants out of from 8 research institutes at the Russian Federal Service for Surveillance and Consumer Rights, hygienic institutes, and this research particularly shows that immunization is taking place, is ongoing. In different regions, there are different results, different ways, and it could seem a paradoxical way, but in such huge cities as Moscow and St. Petersburg, the natural way of immunization is not so rapid as we could imagine previously, because this is a more versatile system than the systems in the regions with the plain distribution of population. Therefore, without active vaccination, without additional immunization by means of vaccine, of course, we will not be able to cope with the actual epidemics. And as of today, you know that we have registered 3 vaccines. There is a question, or it is out of question really for the next year that there will be new vaccines. I have no doubt in this, and the ones who are aware of the latest news know that there is a new line of mucosal vaccines, for example, including the other types of vaccines. It is also a subject of many discussions. We arrive at many questions, and one of the questions here that is also very important for the professional community is what vaccine to choose. What are the indications to prescribe or not to prescribe? Therefore, what are the counterindications also for a certain vaccine? As of now, as of today, all vaccines have the similar position, similar rights, and similar framework of use. And I'm clearly stating this because I understand what I'm meaning right now, because there is a certain set of indications and counterindications for the vaccines. But in the right slide, part of the slide, there are the groups of diseases that we've already covered today in the today's presentation that are naturally bearing some problematic views from the medical society. What does it mean? The part of the society, community will state, you don't have to make immunization in this case. I would state that we need to work step by step. We need to run limited clinical tests for these risk groups. And step by step, again, we can use this experience for broader and broader cohorts. And if we speak as an example about primary immune deficiencies that we were speaking about today, even for this category of patients, if there is a sufficient compensation of replacement therapy by intravenous immune globulins and so on, for these patients there could be a need, under control of course, in a limited way, for on the basis of primary centers for primary immune deficiencies. It is necessary to run this kind of research, and at the end of the day, what do we have to be prepared to in a year or in 2 or even in 3 years is this step-by-step shift to personalized medicine and to personalized set of vaccines or collection of vaccine that would be optimal for this particular person. Thank you. Thank you very much, Oleg Artyumovich. And now the last presentation will be made by Artyom Basov, PhD in medicine, head of the Laboratory of Surveillance for Diphtheria and Pertussis at the Moscow Research Institute of Epidemiology and Microbiology, Russia. Gabrichevsky Institute. Artyom, the floor is yours.
Thank you very much for giving me the floor. Thank you for inviting me to speak to this very important conference. Dear colleagues, the diphtheria and pertussis infections, despite the fact that we had a successful and massive and efficient vaccination, still are quite severe, and we still face some lethal cases. In Russia, the mass vaccination against the diphtheria and pertussis started in 1956, and it actually allowed us to decrease the morbidity by 20 times. And starting from 2002, the vaccination against these diseases raised to the level of 95% in the subsequent groups. Despite or against the backdrop of the vaccination, the diphtheria morbidity during this 10 years has been about 0.01 per 100,000 people. Currently, we register the cases only in 4 territories of the Russian Federation, and the infection is bad or born only in 7 territories of the Russian Federation. And currently, we use some specific methods to assess the quality of and the efficiency of the vaccination. So, serum monitoring of the diphtheria is done in the 7 indicators groups by the special method, and on an annual basis, we get the data to our institute from all the territories of Russia, and the data indicates that the seronegative share is 10%. And this means that the epidemiological situation is quite a good one. But during certain years, among the people over 60 years old and older, this indicator has been higher. And we also see that people have lost the sight of this infection because we've almost forgotten about it. We know that the serum monitoring isn't done in all the age groups, and that's why we can't really assess all the aspects of the vaccination against all age groups. And at our institute, we also do the control research of the blood samples from the indicator groups from different territories of Russia. And we also conduct the quality assurance and assessment of seroquality in different regions. And all this allows us to understand what is the level of vaccination in Russia. So the pertussis infection in Russia is spread almost everywhere, and the morbidity is between 3.2 and 9.8 among 100,000 people. But the picture is quite far from homogeneous, and well, the average indicator is about 5 against 100,000 people. We see that over the last years, the vaccination has been quite spread one, but unfortunately, this infection still leads to some deaths. primarily, this is about children that haven't been vaccinated during their first year of life. Last year we had 2 death cases from pertussis. Those were the children under 1 year, and they were not vaccinated. In general, in Russia, we see that the most vaccinated children are from 4 to 7 years, and when it comes to the intensive indicators per 100,000 of this year, or of the people, we see that the morbidity among them is quite a large one, and that's how we indicate that this is epidemiologically significant. When it comes to the morbidity of pertussis, the most risk lies among those who haven't been vaccinated and children or babies under 1 year old. Also, school children are quite susceptible to pertussis. Our coverage is still a large one, but the post-vaccinal immunity is being lost over the time. And we see that the structure of the pertussis infected people and the proportion of vaccinated and non-vaccinated people, we now see all these indicators in 2010, in 2019, and in 2020. And we see that the picture is all the same, just across all these 3 years. In all the age groups of infected people, we saw some mild and severe stages of infections. The severe statuses registered among the children under 1 year old, and this is another confirmation that this is a risk group. And among the adult people, we see that there are more mild cases, so they do not suffer from the pertussis so much. And we also register some hidden or not visible forms. Among children under 1 year old, we see that the most of them were about 2 or 4 and 6 months. They were during the stage of vaccination, or maybe they were not vaccinated at all. So those children weren't that active socially, and we believe that this is very important. Today, we see that the contacts of children under 1 year old are quite narrow ones. Those are relatives, parents, and medical staff. And in Russia, the pertussis among children under 16 or over 16 years old are not registered at all, and almost at all. And perhaps the pertussis is taken for something else. As to the social strata, 32% of those infected by pertussis were those people who haven't worked, and those probably mothers that were on maternity leave, and about 32% were the office workers. Well, actually, the hidden forms of pertussis is one of the major problems. Some large outbreaks can be registered with the large children groups. Last year, in all the hotbeds of pertussis were among families, and so the contacts are always within the family. So social monitoring today is not that informative, because it is limited only by one age group from 3 to 4 years, and there's only one method of studying this infection. And when it comes to the immunoferment analysis, we see that the share of seronegative share was about 50%. And well, when it comes to the age groups over 50 years that had some antibodies and immunity to the pertussis, shows us that most of these people have already got over pertussis. We also studied some data from medical staff from clinics, and 34% of people had some specific antibodies to the pathogen of pertussis, and about 50% of pertussis-prone people was registered among young employees, medical staff, as well as among those who were over 50 years old. The average age of those who studied was about 43 years old. So seropositive medical staff in age groups with more than 30 years of working experience with children suffered probably from pertussis. They didn't know about that, and it could be the source of infections, and they could have transmitted this infection to other people. And also, we studied IgA and IgG data, and we've seen that indeed some people suffered from pertussis without even knowing it. One of the patients that was studied for that was coughing during 14 days before the test itself, and he didn't ask for any help about it. So we can say that according to the current sanitary norms, the medical staff, as well as adults that are working in medical and children's hospitals, should be studied, those who have been in contact with pertussis. The vaccination of people is implemented in European region quite a lot. In our region, in Russia, before the coronavirus, we asked for the immunization of medical staff, staff of schools, social authorities, to decrease the number of infected cases among babies under 1 year old. In the strategy on the development of immunization up to 2035 that has already been mentioned today by Irina Viktorovna, we see that one of the main elements of immunization and implementation on the improvement of the calendar of regular immunization and epidemic-specific immunization, it all includes the plan for revaccination of children of 7 years old, 14 years old, and over 18 years old. We see that mostly babies under 1 year old suffer from that. And we believe that we should pay attention to this particular group. It's very important to be timely with prevention and vaccination and to observe the right periods in before the vaccination. And we will also use cellular vaccines for those children or babies under 1 year old. And the prevention and vaccination against pertussis, the respect for epidemiological rules and methods will help us to prevent pertussis among all the ages, especially among children and babies under 1 year old. That's it from my side. Thank you for your attention. Artem Alexandrovich, indeed, this is a very important and interesting topic. It's been discussed quite a lot. We discuss a lot the development of the immunization and prevention of immunization against and prevention of pertussis. I would also like to pay or to draw your attention to the immunization against diphtheria. Fortunately, we did some or made some step behind. During 90s, we did have an outbreak of diphtheria, and now we have to set up a task for ourselves not to roll back to those times. And we have to make our medical personnel to be very careful about this disease. And we need to proceed with the regular immunization of the whole population against the diphtheria. And to draw some kind of a conclusion of this session, distinguished speakers, I would like to once again thank you for your very interesting, extensive and valuable reports. I'm sure that they would be acting as some guidelines for our audience today. I'd like to focus our attention on something that our pediatricians, our managers, coordinators, immunologists, our practitioners, such as Artem Alexandrovich, mentioned, because all they represented some analytical data. So to sum up, first, we need to provide the access to the immunization of our population. And this is the guiding principle that is enshrined in the immunization development strategy of the Russian Federation, and I do hope that other countries do the same. Secondly, immunization should be a lifelong, from the very birth and to during the whole life. This is another guiding principle that is observed in the National Healthcare Program, and it is also enshrined in the documents developed by WHO. Another aspect that I would like to draw your attention to is that there is an ongoing fight against the anti-vaccinal sentiments or lobby. And today, one of our speakers already mentioned what are their tools, the tools of people who are against the vaccination and who are lobbying against the vaccination. And we need to proceed with the immunization of our population in such a way that we should convince our citizens that all children, all adults can be vaccinated. And we need to first, of course, define the status, the situation, and taking into account all these conditions, we can develop an individual plan of immunization for some particular and specific patients. Well, our strategic document that has been mentioned before is the main one. It outlines all the main positions of our work, such as the improvement of the national immunization program, enforcement of our production and the technology, as well as the provision of the safety of the immunization. Irina Viktorovna has said a lot about it. She was very clear about that, and I think that will be guided by this document in our future deliberations. If you don't have any questions, and actually we are quite short of time, and we can't really discuss some questions right now. If you still have any, please send them in the online mode. And now I'd like to finalize this session and invite everybody to come to our lunch that has just begun. And also, on behalf of everybody, thank you very much, dear Albina, for your good moderation of this particular session. Thank you very much, dear colleagues. Good luck and see you.
глубоко уважаемый
Distinguished colleagues, I want to invite you to take your seats. Let us start in 1 minute. We have a minor change in our agenda. Instead of Yulia Viktorovna Demina, the parallel session will be held by us, together with Alexander Alexandrovich. My name is Semyonov Alexander, and I am the head of Yekaterinburg Research and Development Institute for Viruses. And this is the only one minor change. And everything else will be according to the agenda. Thank you.
Василий Юрьевич, у вас там презентация.
Vasily, I hope your presentation is now working. distinguished colleagues, unfortunately, we see that the first presenter is being late, the Deputy Minister for Healthcare and Social Development of Kyrgyzstan Republic, Viktor Ganov Ulugbek Tursunovich. Therefore, I would offer the following. Let us not waste the time and let the floor to the second presenter, Marchenko Vasily. He is the head of the laboratory, leading scientific operator of Vector, for the topic of monitoring for circulation and the research of flu on the territory of Socialistic Republic Vietnam. I hope you are ready. Yeah, let us start. Because the first presenter is now on the meeting, and as I understand, they are a bit late. Therefore, let us start from the second presentation, and then we will proceed from the first one after the second is done. Greetings, distinguished colleagues. Let me introduce to your kind attention the results of our cooperative activities. Activities of the State Scientific Center Vector and the Russian Vietnamese Tropical Research and Technology Center for Monitoring on High Pathogenous Flu Virus within the framework of the decree of the Government of Russian Federation. And here, for the realization of this governmental decree, Vector, together with the Tropical Center, is solving the following tasks. The execution of cooperative research work in terms of circulation, of monitoring of circulation of the flu on Vietnam territory, running of training seminars for monitoring and for profile specialists of Vietnam Socialist Republic, and development and issue of scientific and methodology complexes and sets of documents for the specialists from Vietnam. And here today we will speak about the first task. And speaking about the task, we need to stress it out that Vietnam is one of the key regions in the ecology of evolution of flu virus. By a flu virus, I mean the human season flu virus and zoonotic variants with pandemic potential rooting in birds and swine. Socialist Republic Vietnam faced this global virological threat already in 2003 during the outbreak of high pathogen bird flu. And starting from this time in Vietnam, we see an annual registering of at least 30 outbreaks in birds. And along with this, we've registered 127 cases of human-derived diseases with 64 cases with lethal outcome. Vietnam is connected to Russia by one of the biggest migration routes of wild birds, which that are the main owners and main flu distributors. And monitoring of flu virus on territory in Vietnam will provide for a timely disclosure of new viruses and taking the decision on anti-epidemics and anti-episodic events in case of the viruses on the territory of these countries. Monitoring of the flu virus is started together with us from 2017. Together with the operators of Vietnam Tropical Center, we've collected the biological samples taken from birds. We've organized different expeditions in Vietnam, in several regions in Vietnam. In these provinces, we've collected samples because of the fact that previously there were registered outbreaks of highly pathogenous viruses in birds. We've collected also biological materials on markets where live stock is sold, and also in private households. And by the way, private households were very important for us because we've managed to register the fall of house birds. We've collected several dozens of biomaterials, partly from swine, partly from birds. We also managed to collect 150 serums, blood serums, from residents in Hanoi and from people who were in contact with the dead birds. And on the basis of the research of this material, unfortunately, in this year we could not show or could not find the flu virus. But on the basis of a research of blood serum in certain Vietnamese citizens who were in contact with these particular birds, we've seen antibodies to the flu virus H5N8. And in these particular people, in whose blood serum we have seen the antibodies, there were no clinical manifestations, no clinical signs of the disease, and probably, or perhaps direct, there was no direct infection in these cases, but we cannot exclude the fact that the shaping of antibodies in contact persons could be the fact at asymptomatic course of the disease. And arriving at the grounds and the reasons for presence of antibodies in the blood serum in these people needs additional molecular genetic tests and research, and for these purposes, starting from 2018, we are collecting on the annual basis the serum samples in Vietnamese citizens for an in-depth research. Here I need to say that the absence in the clades of virus that were inoculated in 2017, it is due to the fact that we've collected material after the outbreaks, together with operative works and monitoring facilitation on the territory of Vietnam. Therefore, we're asking to revise the system of collection of biosamples. At that time, we've offered the experience of Rospotrebnadzor, of the Russian Federal Service for Surveillance on Consumer Rights and Human Well-being. And in 2016, the Russian Federal Service for Surveillance on Consumer Rights, Protection and Human Well-being introduced the system for monitoring of the bird flu, and we have also a set of decrees of the head of the Rospotrebnadzor Federal Service for Surveillance of Consumer Rights. Protection. This is also a part of the work of the Center for Hygiene and sanitary stations. For example, we are working in the Khabarovsk region, in Novosibirsk region, and in Krasnodar region. Regional agencies, state agencies under the Federal Service of Surveillance on Consumer Rights, Protection and Human Well-being are cooperating with the other state agencies, also with collection of the samples and biomaterials from the birds and swine, and all the RNA samples with RNA of flu are provided to the vector for in-depth study of virus potential. And starting from 2013, together with the regional centers for hygiene and epidemiology, we've collected in Russia more than 50,000 samples with materials taken from home animals and wild animals, also from people. And if in 2013 we had only wildlife probes and a huge amount of domesticated or domestic probes, in the next years we've increased the sampling range, and in 2015 we were also collecting samples. We started to collect samples from mammals, sea mammals also, and human beings. And starting from 2017 we've seen the vast variety of types of flu. We had more than 150 stems or clades of different subtypes, and the majority of variants of flu was seen in wildlife birds and in wild birds, and the majority of the clades that were inoculated were evident in home-grown birds during the outbreaks of epidemics. And on the stages, we were able to see the variants of flu, and which provided us for operative reaction which also shows that we have a very efficient system of monitoring. And to realize this system of monitoring on the territory of Vietnam, in 2018, we've conducted a set of discussions with the Ministry of Agriculture in Vietnam, and we arranged the reference diagnostic and collection of samples in tropical center with the further in-depth study on the premises of Vector. And according to the results of the agreements, the Tropical Center entered into an agreement with one of the 7 regional laboratories at the Ministry of Agriculture in Vietnam, which provided us with the necessary amount of biosamples. And at the end, the collection of biosamples is performed on the places of outbreak with participation of laboratory of Ministry of Agriculture in Vietnam. The differential diagnostics is put within the Tropical Center, and the positive samples are completed and set and preserved in this tropical center. And according to the acting law, to the governing law, there is a procedure for sending of the samples to Vector. And here, in September 2018, according to the agreement that was outlined, the collection of biological samples was already performed, as I stated before, and more than 100 samples from the diseased birds were collected during the outbreaks on the territory of Vietnam. And the laboratory of Tropical Center made it clear that out of these samples, in 31 samples, we have a genetic material of a flu virus. That means that a half was related to the H5N1, and the second half was related to the H5N6. And these positive results made it clear that we need to run in-depth molecular genetics and virological research that should be conducted on the premises of Vector. And to provide this material to the site of Vector, according to the acting law of Russia and Vietnam, we've got all the necessary documents prescribed by framework from the Russian side and from Vietnamese side, and we've got these samples. They arrived at our premises. And I want to speak about the viruses per se directly. While studying their biological properties, all the viruses that we've studied have shown high virulence. This is a really high grade of virulence, and it turned out to be also a part of a feature of a high titers of infectious properties, and also the stamps and clades that were studied. They also showed the high grade of virulence for mice at the correspondent tests, and the high infectious lethal doses have proven the high pathogenicity for mammals. And the results of a research of antigens have shown that the stems under research are similar to the H531 clades 2321 in Russia and the candidate vaccine stems that were recommended by the WHO. The results of a research of the stems of H5 and 6 have shown that the studied stems have roots, the same roots as clade 2344, and together with these studied stems, we had the delineation between 2 different groups. For example, the stems number 73, 74 in the lower part of this chart, they have shown their closeness to the H5N6 that were circulating in Russia starting from 2014 to 2017. And at the same time, the stems under the numbers 1 and 2 in the lower part of this chart were not showing any antigen close lines to the virus of 2014 to 2018. The data is also corresponding to the phylogenetic analysis, which showed that this H5NX is related to clade 2321 and H5NX is related to clade 2344, and also their closeness to the candidate vaccine stems that were circulating in Russia starting from 2018. For example, and especially here you can see that the stems that were seen in Vietnam, so these evidences are really close to the stem that was seen in Saratov in 2018. And as of 2019, according to the plan that was set previously, we worked further in an in-depth monitoring of flu virus on territory of Vietnam. And at the same time, in 2019, we have arrived at the agreement that we will collect material from another regional veterinary laboratory at the Ministry of Agriculture in Vietnam, which resulted in the broadening of geography of biosampling. In 2019, we've collected samples from birds on the territory of 6 provinces in Vietnam. We've got several probes from biomaterial samples from home birds. You see the outbreaks in red on this illustration, and also in orange color you see the livestock on the markets that were subject to our research. And we've got arrived at 35 viruses of flu, H5N1 and H5N6, and 28 of them were representing H9N2 virus. And speaking about the H5N1 virus, so as the previously detected viruses on the territory of Vietnam, they are highly contagious and virulent on the basis of the research of laboratory. And in antigens, they were close to the clade 2321 in the reference viruses. Phylogenetical analysis of H5N1 virus has shown that the viruses that were seen in Vietnam on the clade 2321 have the high identicity grade as the stems that were circulating in Vietnam in the course of several previous years. And when we speak about viruses H5N6, this subtype of viruses turned out to be also highly pathogenic. It is also evident on the basis of virulence features on the previous stems. And as in the previous years, H5N6 viruses have antigen differences and were divided into 2 groups. Phylogenetical analysis has shown that these stems are related to 2 different clades, 2344H and 2344G. And these stems have also a high level of identicity with the stems of the same clades that were circulating during the previous years. Therefore, we may state that Vietnam, as of now, is an endemic region for highly pathogenous virus of H5N1 and H5N6 viruses. And circulation of these stems and viruses on this territory, together with the risk of export of this virus in other territory, also to the territory of Russia, is persisting. Along with the viruses of H5, we've managed to see the virus H9N2, and these viruses were seen and were evident on the markets of livestock. And at the study of biological properties of certain stems, they have shown high level or high grade of infectious features, but they turned out to be not pathogenic for chicken embryons where we are cultivating and for laboratory animals. At the same time, antigens features of these viruses have shown a certain difference here. As you may see on the chart, we can delineate between 2 groups. The stems are related to one and the same genetic clade. And here on this phylogenetical tree, we can see that the stems are generally stacked in 4 different groups within the representatives of one clade, which is corresponding to the study of antigen features. Therefore, within the framework of this work, Vector, together with the Russian-Vietnamese Tropical Center, was successfully running the tests and research in topics of monitoring and circulation of the virus of flu on the territory of Socialistic Republic of Vietnam, and our collective effort resulted in the flow samples of flu virus and serum of contact people to make an in-depth research of a bird flu. And as of now, we have a state collection of viruses starting from 2015, taking out of birds in Vietnam. Thank you so much for your kind attention.
Спасибо большое.
Thank you very much for your presentation. Do we have any questions, dear audience? Then, if no questions, then one will come from me. Could you tell us, do you plan, well, as I understand, COVID thwarted a lot of scientific programs, but do you plan to continue on this work? Well, definitely, the coronavirus has adjusted our plans a bit. By and large, despite everything, we don't only plan, but we do continue to conduct this work. Even in 2020, in November and December of 2020, we had an expedition and we collected the samples. So we did that and we store these samples right now. And in the upcoming future, it will be delivered to us. And as to the second half of the 2021, as well as for the next years to come, we do plan to collect and analyze the samples. Okay, thank you. Dear colleagues, are there any questions? Please do not hesitate. You can come to the mic. They're all on. Okay, I see no questions coming. Then thank you very much for your report. We have adjusted our agenda a bit. And now let's go back to Viktor Ganov, Uluka Becker-Tursulovic, the Deputy Minister of Health and Social Development, Republic of Kyrgyzstan, and he'll be speaking about scientific and technical cooperation between Kyrgyzstan and the Russian Federation in combating COVID-19. Please, the floor is yours. Distinguished participants to this international conference, Epidemiological Wellbeing, I'd like to welcome you. Welcome, dear members of the panel. On behalf of the Ministry of Health and Social Development of the Republic of Kyrgyzstan, I'd like to once again thank you for conducting this important event. The Ministry of Health and Social Development of the Republic of Kyrgyzstan believes it's important to enforce our mutually beneficial cooperation in the field of the decrease of the reining in the threats and establishing the epidemiological safety in the region. When it comes to digitalization and information communicational technologies, as well as the exchange of information on the threats of the epidemiological nature, we all need to do this to respond in a timely manner. Our Republic is very grateful for our fruitful cooperation with the Russian Federation in such fields as the prevention of infectious diseases, as well as epidemiological measures in the fight against COVID-19. We've been doing this work over 30 years. And over this time, we got the support in the field of our epidemiological measures to fight against HIV. We also trained our personnel and equipped our labs for the diagnostics of HIV and AIDS. And in cooperation of the Russian Federation and proceeding from the epidemiological situation, we aim at the timely identification of those infected with HIV. And our next elements of the cooperation. First, the epidemiological surveillance regarding HIV. Secondly, we would like to introduce the contemporary prevention methods among the key groups and migrants. Also, we'd like to develop our multidisciplinary teams to the end of prevention of HIV and treatment in Kyrgyzstan. Also, we plan to enforce the epidemiological control in connection to HIV in those organizations that render medical assistance. And we also plan to conduct some joint research when it comes to the infectious diseases and training of our personnel. We plan to equip our labs with the contemporary equipment to conduct some molecular research. We also plan to timely respond to the epidemiological situation. And in cooperation with the Russian Federation, we've been doing the diagnostics of all the new cases that have been identified when it comes to HIV. And that's how we can identify the sources of infection in case of new cases. And we plan to conduct some biomedical research of migrants and transgenders. They didn't used to be the target groups when it comes to the HIV prevention in the past. And proceeding from this research, we could plan some measures and events among migrants to prevent HIV infection. And the migrants account for 15% of all our population. And during, or thankfully, to the measures on the prevention of HIV among pregnant women, we increased the efficiency of the programs against the transmission of HIV from a mother to her child. And so the majority of pregnant women as HIV positive get the medication. And as a result, the vertical HIV transmission has decreased from 7% in 2009 to 2002, in 2002, it was 7%, and in 2020, it's just 2%. And we conducted the diagnostics of a newborn baby over just 48 hours. We trained volunteers in rural health committees on the subject of the transmission of HIV from a mother to her baby, and it was all done with the support of the Russian Federation. And we also conduct the rendering of services within the support of the Russian Federation. We maintain 12 multidisciplinary teams and consultants. And the number of accessible clients risen from 49% to 73%. The coverage raised by 3.6 times, starting from 2,053 people to 1,470 people in 2021. So we developed the model of a multidisciplinary approach, and it coincided with the order from the Ministry of Health of the Republic of Kyrgyzstan. And it is about the decentralization of our medical services. Currently, we expanded within the grant of the Global Fund, and with the cooperation with the Russian Federation, we established youth centers in one of our cities in the hospital which registered the most cases of HIV infection among children. And we wanted to render assistance and aid to young people that faced these problems. So we helped also and continue to help children and adolescents that live with HIV. And we purchased 2 sets of sterilization equipment. We also purchased some cleaning equipment. within the program of technical support in the countries of Eastern Europe and Central Asia. So, within the fight against HIV and other infectious diseases, and with the support of the Russian Federation, our ministry, starting from 2013 and till 2021, got 5 mobile clinics for 5 remote areas in our republic. The mobile clinics have studied 253,000 people and tested against HIV 78,000 people. And we also are catching up with the immunization against the backdrop of the COVID-19 pandemic. Proceeding from the agreement between our ministry with Rospotrebnadzor, which is Federal Service for Surveillance and Consumer Rights Protection and Human Well-being, we conducted the immunization against the rubella in the Eastern Europe and Central Asia. And we are working to decrease the infected cases of measles and the creation of herd immunity. From the Russian Federation, we got some help and aid. It's free of charge with the anti-measles vaccine for our campaigns in 2019. We got 100,000 doses, and in 2020 we got 50,000 doses. And in the beginning of 2021, we got 40,000 of vaccine doses against the hepatitis for the vaccination of our medical staff. And we've been conducting a regional project on the decreasing of dynamics, and we're working on those organisms that are antibiotic resistant. And jointly with the countries in Eastern Europe and Central Asia, we try to identify the sources of dangerous diseases, including the cases brought from abroad. We also try to identify the natural resources or sources, and we try to identify the pathogens of these diseases. And we got PCR tests from 205,000 from Federal Service for Surveillance and Consumer Rights Protection and Human Well-being, Rospotrebnadzor, as well as some spare parts for 170,000 studies and tests. We signed an agreement for some deep research when it comes to the circulation of the viruses on the territory of Kyrgyzstan. I thank you for your attention, and if you have any questions, I'll be pleased to answer them. Thank you very much, Mr. Deputy Minister. Do we have any questions from the audience? If you don't have any, I'll get one from me. You will get one from me. So how do you see the cooperation with the Russian Federation when it comes to scientific research and scientific cooperation? Okay, thank you for your question. We used to have the cooperation with the Russian Federation in terms of hepatitis, HIV, AIDS, and special dangerous infections that result in a quarantine. So as far as I understood, you will continue to proceed with this cooperation. Yes, so definitely we will. Okay, thank you. Do we have any questions from the audience? If no, then we'll probably move to our next report. And it will come from Mark Stibich, Chief Scientific Officer, Xanax Disinfection Service, Fellow of the Infection Diseases Society in America. He'll talk about the role of surfaces in the spread of SARS-CoV-2 and antimicrobial resistant organisms. Please, the floor is yours.
Hello, my name is Dr. Mark Stibich. I'm an infectious diseases epidemiologist, and I work in a number of different projects, and I've worked a bit in HIV prevention in Russia and the former Soviet Union. But today I'd like to talk about the role of surfaces in infections and disease transmission, because I think it's one of the areas that's often overlooked and an area where we can step in and create some simple interventions that can really make a difference. So with any luck, I'm going to share my slides here. Here we go. And I just have a few slides on this. So like I said, I'm an epidemiologist, an inventor, and a founder of companies. Here are my disclosures. So Zenix Healthcare and Forefront Healthcare, two US-based companies. So first, as we all know, SARS-CoV-2 has spread quite wildly, particularly in the United States and elsewhere. And so we have that pandemic, but what we also have is another pandemic that's really coming for all patients. We have antimicrobial resistance. So this was a report released by the UK in 2014, really estimating that by 2050, we'd see 10 million deaths caused by antimicrobial resistance with an impact of $100 trillion cumulatively over that time period. And I bring that up because, by looking at surfaces, by looking at how we really spread diseases and being able to mitigate the various pathways, we might be able to make these numbers wrong. Here's the same numbers, but looking at by regional. So in Asia, 4.7 million, Europe, 390,000. So really some of the hardest hit, Africa will be one of the hardest hit places with antimicrobial resistant organisms. And again, these are largely preventable infections based on surface transmission and other means of infection control. So really, point number one in my presentation is that we've put a lot of new infection control in place because of SARS-CoV-2, and we should really consider keeping many of those components in place because we already are working on the next pandemic, which will be much more sustained and much more devastating even than the COVID pandemic has been. This is a quote from Robert Redfield, then director of the CDC, just before the COVID pandemic, and he said, stop referring to a post-antibiotic era, it's already here. And that means that basic medical procedures, basic surgeries, oncology, cancer treatment, things like that, won't be possible if we're facing these antimicrobial resistant organisms, because we simply, they'll not get the immune compromised patients, the HIV patients, will not be able to receive other types of treatment because these organisms are so antimicrobial resistant. How do fomites really impact disease transmission? This is a bit controversial, but it's quite simple in a way. There are droplets deposited on surfaces. Individuals touch the surfaces. There's a certain transfer from that individual to their hand, and then they touch their eyes, nose, mouth, or wound. And we'll talk a little bit about in detail of how this really works. And but it's very, it's a very straightforward pathway and a very common pathway, especially in healthcare and medical settings. Is this really a risk? So we've had a lot of overreactions, perhaps, to COVID. People disinfecting packages and shopping carts, and perhaps in those areas it's not as critical of a risk. But certainly in healthcare settings and in settings where or believe a person who is infectious then the surfaces can pose a risk, and SARS-CoV-2 and other organisms can be deposited at an infectious level. So some surface survival data, we're seeing this come out now. There's been a number of studies now looking at how long SARS-CoV-2 and specifically survives on surfaces. So the half-life or the D50 value, the D values here are 5.96 and then the 1.7. So 90% reduction. So a deposit happens on a surface in 5.96 days, that's 90% reduced. In 1.8 days, that's 50% reduced. That's how to read this table. So bottom line, on various types of surfaces, paper note 9 days, SARS-CoV-2 can survive for quite some time. Obviously, it depends on surface type, and the die-off is variable on surface type, and temperature is a big impact, and sometimes with some organisms, humidity is also an impact. And we see this variability. But what about other organisms? So here's a list of how long other organisms survive on typical dry and animate surfaces that might be in a hospital, like a bed rail, a doorknob, things like that. So we've Acinetobacter, 3 days to 5 months. C. diff, Clostridioides, this is a little old, Clostridioides difficile spores, 5 months. Things like Mycobacterium tuberculosis, up to 4 months. MRSA, 7 months. So organisms can survive once deposited for a long time. And we're seeing, another concept to think about is, okay, we know they're there, but are they really at a risk? Are they really going to cause an infection? In mice, 1 CFU of C. diff caused infections, and 15 CFUs of Staph aureus could cause infections. So norovirus is less than 10 virons. So many of these organisms don't need a whole lot of deposit to cause an infection. So even though we have a D90, they're dying off, they're still causing risk. And this is one looking at specifically at SARS-CoV-2, looking at what's contained in a droplet and what is that infectious dose, and does that really get deposited and survive? Short answer is yes, that is possible. Another thing to consider is what's the transfer rate. So if I have a contaminated surface, when I touch it, not all of that organism on the surface is going to transfer to my hand. And then if I touch my mouth, not all of the organism on my mouth will touch my hand. So it's important to think about what is the transfer rate of these organisms. So if I'm wearing gloves in a healthcare setting versus hands, what is the transfer rate? How much transfer? So that's an important part. And different surfaces are better at transferring. So the hard or smoother surfaces transfer a higher percentage of their contamination than a porous surface. So the pathogens are evolving. We've got emerging pathogens like SARS-CoV-2. We've got antimicrobial resistant organisms. But really our tools to disinfect the environment haven't changed. These are still buckets, mops, wipes, and chemicals. And so we're really looking at a problem in the healthcare setting, in settings where people with these organisms are present. When you see a healthcare system disinfected, about 40% of the surfaces are disinfected poorly, and 52% of the surfaces are not even cleaned at all. So in between patients, the cleaning is very, very fast, and it's not very effective in terms of hitting every surface. This slide shows where some E. coli, some drug-resistant E. coli was present, and you can see all those excesses. This is after this room was cleaned and disinfected by housekeeping. There's still pathogens on the surfaces. And this is another slide showing this. This is a compilation of multiple studies showing what surfaces are most likely to be contaminated. Here's just a little cartoon. Pause there. So what does that mean? Does that mean there's actually an increase in infection risk? Well, there's something called the prior room occupancy risk. This is the risk of a patient who had, if you enter a room, if you're a patient and the patient before you had MRSA, how much higher is your risk of getting, for example, MRSA or VRE? And here we see quite high odds ratios, 1.4 for both VRE and MRSA. So there's an increased risk. In this other study, it was a risk of 3. So 3 times the risk if the patient before you had that organism, which really shows there's something going on in the environment that's causing the spread of these organisms. Here's some more of that same type of data, looking at these odds ratios are, so 2.35, 1.9. So quite an elevated risk consistently showed for just that next patient in the room. That doesn't mean there's not other risk involved too, because many studies show that the organisms don't remain just in the patient room, but they spread outside to other areas of the hospital. How does it get transmitted? Lots of different roles, but basically contaminated surfaces go to hands, go directly to the patient, our healthcare worker hands, recirculate. There's something called secondary migration where they get into the air, and there's also direct patient contact. So in summary, when you're thinking about the role of fomites, our surfaces, in disease transmission, you have to look at survivability, you have to look at surface type, the infectious dose and the likelihood that organism would have been deposited, in other words, that someone with the infection was present in the room, the likelihood of contamination, the susceptibility of the next person. So an oncology patient versus a healthy person, they're going to have lots of different susceptibility and different thresholds of infectious dose. And then how are those areas being disinfected? What are the methods being used? Are they automated? Are they audited? Are they reviewed continually? Are they missing surfaces? So in conclusion, 2 things really. We need aggressive infection control measures to stay in place even after COVID. We're seeing antimicrobial resistance emerging and emerging pathogens, and we're going to need to continue to fight those. And fomites are an often overlooked source of disease transmission, and we should focus on those. They're actually a somewhat easy place to have a large impact on disease transmission. So thank you very much for your time today, and I hope you have a great conference.
Unfortunately, because of the time differences, Mr. Stivic had his presentation done beforehand, and we have no questions right now. We are not able to ask them. And now I want to go to the next question in the agenda. Samuel Markaryan advisor to the Health Minister, Republic of Armenia, and he will speak about the using of centralized health information system to combat COVID-19 in Armenia. And I want to use this case and remind you that in Armenia, starting from 2017, we have the centralized system of healthcare, but this novelty was introduced recently. May you put my presentation on screen, please? Greetings. Distinguished ladies and gentlemen, today we will speak about the use of centralized information system of healthcare in the framework of the fight against COVID-19 in Armenia. Just a couple of slides I want to show you beforehand what is this centralized information system that is working in Armenia, and then in a live mode I will show you our server and the results of work of this system. Just briefly on the structure. The RMET system, as Mr. Bazarchan told, was created in 2017, but the real application of this system started in the beginning of 2020 when we began actively use it during the pandemics. What is it? Its structure unites all medical agencies and hospitals in Armenia, all 129 medical centers, 296 ambulatories, and 56 laboratories are using this system and are a part of this system. There are more than 4,000 active users within the system, and in the real-time mode they are entering and putting information into the system. The system is joined to the main information system, state registry, tax service, and Ministry of Education. What does it mean and what does it give us? This gives us in 99% precision of the information. That means the doctor cannot only give in the information like name, family name, and date of birth. The doctor should find the patients in the registry of population and add information about COVID or any other medical information to this profile. And this practically is providing for avoidance of mistakes, of any mistakes, entry mistake, double introduction. And for the moment of probe, so for the moment of the first contact at COVID, the setting in analysis, we have a full dossier on this person. At 80 units of information related to this person, starting from the information on birth, date of birth, how many children, where does this person live, where is the place of official registration, place of work, place of study, if this is a kid, child, or a student, or a teacher. And this is always a very vital, important information. And this information, we are working with it directly after or during the first contact with this person. And here, just briefly on the second slide, I will show you what is the process related to COVID within this framework. So the workflow looks like this. In gray, these are 3 million people who live in the Republic of Armenia. And whom do they contact? Almost all medical centers and ambulatories and laboratories themselves take their probes for COVID, take the tests and run the tests. Along with this, we have also a great operation of the local or house tests. That means test collection can be done in 5 minutes walking range from your house, or for additional $10, they will visit you and take a blood sample. And the next information is downloaded to the system RMET, and then the laboratory has approximately 6 hours to give negative or positive a response. And this is also very important, and this is also a subject for proper monitoring, because we see all the laboratory data in a real mode, and if there are some demurrage periods or waiting periods, they are put into the red zone, and even on the level of ministry we can see it. And in case of the negative, whereby this is the best case, in the numbers I wanted to show it, we have about 1 million of analysis from the beginning of pandemics. What is happening after the positive response? After a positive response, all people who have got the positive response are distributed into small groups for primary doctors and primary chain doctors. We have all the primary tier of the doctors put into the RMED system. That means that the system is automatically notifying the doctor primarily that one of your people or the people has the positive analysis. And the doctor of the first tier is connecting all positive patients. These are not many people. The maximum are 10 people a day in our setting, and we have 2,700 doctors, and every doctor is curating approximately 2,000 people. And there are two variants. The doctor of the first tier is filling in a digital questionnaire, and the digital questionnaire provides for an automatic rating of the diseased person. That means our doctor have provided some parameters like temperature, the diseases, comorbidities, and so on. And this is also the rating of a diseased person. If the rating is lower than a certain level, then it is followed by the home's self-isolation, and this information is filed to the police and to all agencies that are controlling this situation. Or there can be a second variant when the doctor of the first tier is taking the decision that hospitalization is necessary. The information is sent to the 3H center, and 3H center, TRIH center, can say that no, you are setting the patient to sit at home or hospitalized. The TRIH center has the access. That means the access to this to the workflow and the full network of like 3,000 of beds is also a part of the workflow. We have all the information and digital access to the ambulance cars that are set especially to handle COVID patients. And then hospitalization. Then the hospital is also supporting the information, the filling of information within the same workflow. And then a follow-up. And the same is also made by the doctor of a first tier for the people who are staying at home and who are isolated at home. And the program is set like this, that if the doctor of a primary tier has forgotten in 14 days to ask patients or to call the patient about the status and to understand what happened with the patient, the program is automatically checking the state servers whether the person has deceased or not, and if the person is not deceased, it is deemed to be automatically cured in 16 days. That means we have a gap of 2 days that is provided for the primary care physician. And all this information in every time, in every place is accessible for all parties concerned, for all management levels. And now I will just try to show you what are the results that we are dealing with. This now is the real-time information, what we have. The numbers are the numbers. Yes, I know the language is Armenian, so I will tell it to you. 209,802 cases of coronavirus, positive cases of coronavirus during the whole pandemics. The first part are the overall numbers. Now 14,970 are the people under survey. Deceased 3,927. So 71 year is the median age of the deceased persons. And then there is the information about the today. That means right now how many people are registered today. Starting from 0 and until now, we have 310 new cases, already 12 deaths related to coronavirus and 2 deaths related to coronavirus but not bound to coronavirus. Other reasons means, and this was discovered during the first months of the system, like for example, you can get in a car accident although you are having a positive COVID status, and there are some deaths that are not bound to the coronavirus, right? Like death in the nature, in the woods somewhere, and this is all just a classification matter. And we have a network of laboratories, as you can see here. As of now, today, 1,737 tests were done today, and here is the distribution for laboratories. And in the first part, I told you that we are also integrated with the tax service. Yes, we have all the graphs here, all the curves, like curves of death cases, morbidity, mortality, sex, and so on and so forth. Look, there is a chart. It is also stated in Armenian, but these are the real-time modes for diseased persons according to the workplaces. Because in the real time we see the different organizations, like for example in April or in May, at the beginning of pandemics, in the textile enterprises, in some schools, in some departments, in banks, we could see this information, and this information is actually provided during 1 second to us. Nobody is working additionally to make statistics. Like we have an order from the Ministry of Healthcare or from the Center for Counteracting of the Infectious Diseases, and we are just showing this dashboard and working with this dashboard. And at the end, we have also loads of beds and free beds, for example, in certain hospitals. What are the time frames for the patients stay in hospitals? And this is also an automatic map of self-isolation in the real-time mode. And the left side is Yerevan city, and on the right side you can see the whole Republic of Armenia. And the lighter the color is, the better the situation with COVID is as of now. And here we see also different regions. And the number 2,129 is just the amount of people, the quantity of people who are hospitalized as of now. Shall I have any questions? I will be delighted to answer. Do we have any questions from the hall? And from my side, I want to say that this instrument is very suitable for the persons in charge, and also for the scientists who are arriving at certain ideas or are writing their articles. Do we have any questions? Please use the microphone to ask the question. Thank you very much. This is a very great, interesting presentation. I have only one question. Do you have information? What is the mortality rate in Armenia? Because these numbers are really a bit frightening. So lethality or mortality as of now is 1.8071%. We have this information for every minute. Who else? Yes, please, you may ask your question, of course. Mr. Deputy Minister, you may ask your question. Yes, thank you very much. Now you've told us for how, when the positive result is seen, that you are sending the person for quarantine for the next 14 days. And you told us in your presentation that if under the home quarantine the person dies, like, for example, if there is a car accident or a certain accident, then you are not controlling this person on the home quarantine, on the self-isolation. So you told this, I did not tell this. Look, yes, I think there was a misunderstanding. It is not so easy to control everything, but it can happen. That's life, but this is just a marginal example. There was just only one case of this. The main reasons for this kind of deaths are different. These are the deaths on just level of the doctors. They are assessed. Look, I'm an economist in my specialty, but still, the doctors just decided that the reason for the death is not COVID in 90% of this case. Mr. Markarian, I just want to ask you, Yes, I know you are an economist, but I am more in the healthcare, and I may state that this death is fixed as the death with COVID, but due to the external factors. That means, because of this, I wanted to state that even these cases, if you have COVID and you got in a car accident and died, you are also subject to anatomical research as every person deceased from COVID. And because of the special decree of the Ministry of Healthcare, this double check is done for by the correspondent pathology and anatomy laboratory, and the coroner's activities are done within the decree that is applicable to all COVID patients. Thank you. And one more question. If a person if a person will go out from the quarantine, how many people can get this virus? What do you mean? Please, could you please define? But look, you are speaking about the case that there is a person under quarantine, there is a virus positive person. How many people can get the disease? Look, it all depends on the time. If you went out for 1 second and then you are killed in a car crash, then you may not infect anyone. But if you went out to, I don't know, to go to the to some festivities or to some festival. So theoretically, this can be the case, the major case of infection. But legally, if you went out being under quarantine, self-quarantine, you are subject to prosecution. But still, in such cases, we are investigating all the contacts of this person during the recent time, and even by the numbers of phones, we are calling to the persons who were in contact with this particular person in the recent time. Thank you. Yes, thank you for your report. Shall I have any questions? If there are no questions, I think this was the last item in our agenda, and we are finalizing right now our session. So the session is closed. Thank you for your kind attention. Thank you for listening until the end, and thank you for your participation.
but I've heard that we have a lot of visitors on our online portal. So I'm the chairman of this section, and first I'll give the floor to myself and will present to you. I hope that my presentation is working well. Today, I'll try to talk about the main trends in HIV research, but first I would like to mention why we need them. We see some quite successes emerging in the field of the fight against HIV. The next slide, please. Having some troubles clicking on the slides. Okay. So, for more than 10 years, we've been having a strategy in the fight against HIV infection. This is the strategy called Test Up, Test and Treat. And it was proposed and suggested back in 2009. Currently, this is the main strategy. What is the gist of it? We have to diagnose the HIV infection among everybody who are infected, and we have to apply antiretroviral therapy on a lifelong basis, so the life expectancy will increase among those patients, and then they can live for 30 and another 50 years. And we can expect that the number of infected cases in 50 years will be going down to zero, and those who are infected right now, for example, they currently can be 10 years old, they will live up to 75 years, and we can say that in 75 years we can say, or will be able to say, that we'll have zero cases of new infections. And this program and strategy has spread quite a lot. The main idea of this is that we have to get tested. If anybody is HIV positive, then the treatment should be applied, and it all will end quite well. And if we take a look at the current state of affairs in the reality and at the development of this campaign, we do see that the number of newly diagnosed cases is decreasing. But still, we've seen a recent publication saying that 1.7 million new cases appeared in 2019. Unfortunately, this is not in line with the concept that was approved before, and it all happened before COVID. So we expected the number of new cases to be less than 500,000 once, but this figure in reality is 1.7 million. And some groups even experienced the growth of the newly infected and diagnosed cases. So unfortunately, this program is not going as it was expected. And there is another strategy, the global strategy on AIDS, and it is about to decrease the number of new cases up to 370 by 2025. And the number of deaths should also decrease quite significantly. But if we calculate how many new cases we will get over this 5 years, we'll add 4 million of new cases. And here you can see the Russian state strategy on the fight against the spread of HIV in the Russian Federation. It is adopted up to 2030. And by 2025, according to this strategy, we will indeed, or should indeed, experience the decrease of the new cases up to 58 new cases per year. And as to this plan, according to this plan, minimum, we will get 344,000 newly infected cases. And by 2030, we expected to get the figure of 656,000 new cases. And speaking worldwide, it will be equal to from 3 to 5 million of people HIV positive. And in Russia, we will get an additional number of more than 500,000 of people, and we will have to treat them over the upcoming 75 years. And this strategy, check and treat, of course, it will decrease the death rate connected to HIV, but it will result in the increase of financial, organizational, labor costs that are connected to the organization of HIV treatment. You do understand it all yourselves. This strategy also has some weaknesses, and they demonstrated themselves quite clearly during the coronavirus pandemic. First, it depends on the loyalty and readiness of the government, whether the government will allocate money or not. Some governments do not allocate any finance, they are just hoping for the financial aid from rich countries, so to say. This is not a very good thing to hope or to be relying on, because this is a very subjective element. Then there is also an issue of the financial stability, reporting, as well as whether we'll be able to build some loyalty here. And if there is no loyalty and its confirmation, then we can face a situation of the worsening of the situation. So probably we have to suggest something else. And subjectively speaking, I don't think that anybody who are HIV positive, I don't think that they would like to administer antiretroviral medication. Today, we've had a report on the Coalition on the Readiness of Treatment. Well, the number of pills that should be administered per day is decreasing, but this is not applied to everybody. And still, people have to administer a lot of pills per day. And of course, it all depends on the cost. So 1 pill per day will cost more than 13 pills per day. So the problem is still there, and it persists to be quite serious. So we definitely need to develop our scientific research as well as to finance it. And this point is somehow missing both in the global strategy and in the Russian state strategy of fight against HIV. Well, first, this is about non-specific prevention. We have to provide information, to train. The previous section has told us about it quite clearly, and the International Labour Organization said that they conducted some work in some professional teams. And still, the first question that should be discussed with people is, do they differ, HIV and AIDS? Does any difference exist for them between these two states? And so people do not know. And we also discuss on how to drop the strategy. How should we inform the population, or we'd better train them? Well, informing and training, those are different elements. If you just say on the website, well, be afraid of AIDS, this is informing. But if you tell the people how to use condoms, this is more about training. Whether we'll be conducting this or not, this is all quite complex. Then, in addition to that, what methods are efficient, which are not that efficient, how to influence the population? These questions are all quite complex. Well, the issue of circumcision, for example, for some countries, this is quite a pressing and relevant issue because it can decrease the infection risk by 60%. And, well, in many countries, nobody will do any circumcision. However, our chief sanitary physician in the past called upon everybody to do this, but it wasn't paid much attention to. So all these aspects should be reviewed and supported scientifically. The next point here is the specific prevention, what we usually call vaccination, but currently there appeared another area of studies, the passive immunization. So we can also produce the highly specific antibodies against HIV. We can inject them and proceed with the prevention. Then genome prevention, it's quite common and known. So here we could use some genetic therapeutic medications. I'll touch upon this a little bit later. And when it comes to the cure and treatment itself, definitely we need to improve the current antiretroviral therapy. It is discussed quite a lot, but first and foremost, we have to develop the methods how to cure the HIV infection. This is the most important task of ours. Well, getting back to non-specific prevention, this is a very good example. Well, we've been teaching our population for 30 years that one should use condoms, but for some specific groups of population, it turned out to be very difficult to perform, and some so-called specialists say that condoms are not a protection. And actually, we can compare the situation with condoms with the situation of masks. Well, a lot has been said that masks can only worsen the situation and infection, and then the whole world finally came to the conclusion that masks is, before the vaccination, one of the most common and efficient ways of not getting infected. So this is another example how we can also make people use condoms. Pre-contact prevention. I believe that here it's quite clear. Different medications can be administered. Some of them are registered, some of them are not registered yet. If, once again, I refer to the previous session that we participated in, there are a lot of organizational challenges indeed. However, there are some prolonged medications, and well, you can get one infection for the upcoming 6 months, and you can get any infection except for HIV. And also passive immunization, as I've said, those are protective antibodies. One injection can result in a couple of months of defense and safety. Then specific immunoprevention vaccines. This is the favorite topic of our researchers. They are quite keen about it. But as you know, protective immunity cannot be developed naturally when we talk about HIV. We have to come up with something specific, and 35 years have passed, but no vaccine has been developed yet. Last year, there was a very promising vaccine, and the efficiency of 30% was given last year, but the data has shown that the placebo group and the control group had the similar number of infections. But this research is still undergoing, and perhaps we could see some effect in 2 years, for example. There could be some difference appearing, but as of today, the research has stopped, and only those are monitored that have already been vaccinated, and that's all. And there are some more vaccines coming. The combinations of antigens are quite complex there. And thanks to generic engineering, we learned how to produce them. These vaccines are quite promising ones. And upon the monkey model and their own virus of immunodeficiency, we've seen that the results after the vaccination are quite good, the protection up to 90%. But currently, these vaccines are undergoing trials. And, well, there is some delay connected to a vaccine caused by the coronavirus. But next year, I expect us to get some very interesting data on vaccines and medications. The chemo medication with a prolonged activity also has been working. So cabotegravir, you all know about it. Currently, we are studying isulfavirin, and very interesting medication, capsids inhibitor. And this is not an injection, but this is per oral form, once per week. And if we talk about the intermuscle injection, when it should be done once per 6 months, the results are quite promising. And it could also be combined with the medication manufactured by another company. And it could be that one injection should be done just once per 6 months. But still, it is all undergoing trials, and I don't see it coming very soon. Then the new medication forms, such as antiretroviral medications that are in the liposomes, so they can be delivered right in the cells, and it takes them a lot to get the release, so it produces the prolonged effect. And some other medications that are manufactured proceeding from nanotechnologies, and they are expected to be of prolonged activity. Well, you do understand that this is all very nice, but the main problem of the therapy is to potentially the problem is that there is a persistent potential activity of integrated proviral DNA. So how to get to this DNA? Actually, there are a couple of approaches. Some suppose and suggest that we should stimulate the natural immunity to help the body to get over it on its own. And there are different options that can be used here. Some researchers suggest to get rid of this infected HIV cells. So there could be some markers developed, and we could just kill these cells. There's another approach, the third one. We should activate the proviral DNA, and that's how the antiretroviral medications will kill it. It's called shock and kill. And another approach that is very promising, it is called the genotherapy. There are a lot of different approaches encapsulated in this one. So the genetic therapy, it has different names, such as genetic stimulation, genetic modification, intercellular immunization. So there are different approaches that are quite different from each other, actually. For example, the genome of the cells that are producing antibodies receive the product that would activate these antibodies. And another approach is that one can code the viral antigens to stimulate the immune response. After that, the T-cell receptors are formed, such as CD8, and they will kill the CD4 cells that have been infected with HIV. Another set of genes that can express the microRNA that inhibit HIV, or transactivator of transcription that can also thwart HIV spread, as well as VIF. So all these genes can be transported through different vectors. You've heard about these vectors because of the Sputnik V vaccine against the coronavirus. And what's also very nice is that we can transport the cells that can inhibit the expression of the CCR5 expression. If you remember, there was a Berlin patient, and he had his cells replaced with the cells that didn't have this receptor. And here, nothing should be transplanted at all. We can just adjust the cells of the patient or of a healthy person. So why I said that this genetic therapy can also be used for the purposes of prevention.
If in a healthy person or a non-HIV infected, we will process some changes in genetics, it will be not accessible to HIV. So gene therapy is also a prospectful direction for us. And there is also one additional direction or way of work. This is perhaps not the same thing as genetic therapy, because here we will need to work on with all these terms. This is the entrance into the construction that would edit the human genome, like CRISPR, Cas, that are editing the genes within bacteria and cleaning them from the bacteriophages, from the viruses. And here, according to this analogy, we can create some things that would cut out genetic parts, the parts of HIV genes that are built in the genetic code of a human being. So this is also a matter of active work, and all of these directions are developed in different countries. They are on the different stages. There are some first or even second phases of clinical trials. Therefore, there is a research, and it's pretty active. Another question is how we will measure the efficiency of these drugs. Will these drugs be able to cure the HIV infection? Here there is no consensus here, because many think that it will need a combined approach. And here is a pretty picture that I liked. It was published in one of the reviews, that to fully cure a human being, here there will be an antiretrovirus therapy, then certain special antibodies will be injected, or drugs, into the liposomes. Then it will arrive at the fact that there will be a deletion of all active virus parts, and then perhaps it will be necessary to add some genetic therapeutic drugs, and then at the end we can possibly arrive at the full at a full deletion of the virus from the human body. But what will be the result? We are not able to tell right now. Therefore, again, I will state that it is a huge amount of work. It is done in other countries, but it is not so very well financed in Russia. And again, the next thing, we may create all the drugs, and it is done in a rapid way right now. For example, when we speak about the creation of all these vaccines, several months and the drug is ready. But the most severe and the most complex thing is in the field of clinical trials. Therefore, there is a joke that you can see on the screen that before you get your own flu shot or vaccine, you need to test it on people. That means in preclinical trials on animals and then on human beings. And this is perhaps one of the toughest steps, because this is the longest leg for introduction of all new drugs. Therefore, we created, in face of pandemics in Russia, we've managed to open in December the new Research and Development Center, Scientific Center, the purpose of which is to facilitate clinical tests and trials of all these new drugs that we are waiting for. And this is a well-equipped house. As you see on the premises, we have everything to run the clinical tests. And we, of course, want to invite all the patient organizations to search for the people who are willing to take part at the clinical tests, and for them to take part at our works. And I really hope that this longest clinical phase, the longest leg of our tests, will be performed in a more rapid way. Thank you very much for your kind attention. Yes, thank you so much. Now let me represent Mr. Pomaskin Dmitry Vladimirovich. He is the next presenter, and he is representing the Scientific and Research Fund Gazfond, Russia, with the topic evaluating of demographic consequences of infectious diseases in Russian Federation using the example of HIV infection. Greetings. Our session is providing for this reminding that the quantity of presenters is pretty much the same as the quantity of people who are listening to, and this is the same situation with the doctors and patients in oncology. I want to represent the work that was made in analytical center at the government of the Russian Federation. This work was devoted to creation of mathematic model to assess social and economic consequences related to the HIV. This is not, of course, this is not the first experience in this field, because I think at the very beginning of this millennia, 2000-2001, there was the first model, first approach started to pursue the same goals. And we have a brilliant possibility to take a closer look at what happened during this time and how can we model this. So, let me comment. Could you please help me in managing my slides? Yes, thank you. Now I can see it. This is the contents of my today's presentation. I will tell you today about how we prepared this forecast. I will briefly tell you about the results that we obtained, and I will tell you and show you several directions, new directions in work with scenario models. And briefly, I will touch upon the program part that we've used for this purpose. Perhaps this is one of the most interesting things, and it has quite a potential and can be worked out for the further executions. And we are now going to the next slide. Perhaps I will ask you for certain assistance here. Yes, thank you. Now we can go on. Just a small example from the yesteryears. This was not only the interest of our 2 days' time. When we remember en masse all of our forecasts, the forecasts are not the reality. The reality can change the forecasts, and as Omar Khayyam told, that we are trying to make something up, but the time comes and everything is changed, and we go back to the initial points and try to change our ideas and view. As I told, this version that was made in 2003, in its tendencies and in its overall approach, has pretty much the same result as the previous one, and we are rather optimistic here in the work of our modeling approach. What did we do? As the basis, we've taken the demographic forecast. We had the sex and gender and age pyramid with use of cohort method of shift of ages to count the population dynamics, and we've added to this population dynamics this part that would model directly the processes of HIV. Just a couple of words. It's just a lateral idea. What is HIV in view of the processes that we are seeing in our society? And how far does HIV affect the problems and issues related to the sustainable development? By the way, the term sustainable development is conceptuated in the mid-70s of the previous century, and it is now widely used. And HIV, or AIDS, is one of the barriers here that hinders the development and hinders the sustainable development goals. for how much it can be connected or compared to the other challenges like ecological challenges, environmental challenges. This is the problem, or one of the problems, that is solved by this particular model. So, as the basis, we took the demographics, which is the basis, and this demographic forecast. Again, I want to repeat this. We have added the parts that would model directly the HIV infection. Here we have the results of basic forecasts in demography. It was done before COVID. Therefore, all the effects related to the increase of the mortality rates and increase of the life expectancy of patients, and they were not taken into account, although they were significantly affecting demographic processes, because according to the Russian Statistics Agency, life expectancy for 2020 decreased by 2 years from the moment of birth, and this is quite a change. And more or less, this is not a long-term situation. It will be restored, and on a long leg, it will not change the picture. This is just the median data, and we've used the data that would correlate to the median forecast of the Russian Statistics Agency. What did we do? On the basis of this demographic platform, we've built an epidemiological forecast. Epidemiological forecast is a one-sided shift between the phases of health, healthy, HIV, and AIDS. We've used a multi-decrement model with decrement as death, infectious state, and transfer or shift between the groups. And further, I will tell you about the data on the basis of which we've made our calculations. So yes, basically, what did we do? We've used two main hypotheses. The first hypothesis is related to the infection profile. We've took the Form 61 at the Ministry of Healthcare of Russia, analyzed the quantity of infected persons in 5-year groups, and we've built the possibility of getting an infection. I will also tell you that I will distribute the slides later. I will not wait too much here, and I will not tell you about the change in the ages, but here is the diagram that will show it to you more vividly. What is interesting here? Going back to the things that I've mentioned previously, here we see the probability of getting an infection for males and females with gender distribution for the year 2003 and 2019. What do we see here in detail? We see that the amplitude is pretty much the same, but we have a huge shift to the right side, because the probability of getting an infection, this is a process of evolution dynamics, which states that we have just a shift along the age within the groups. We may think about different facts, but this shift in age is very vivid, and we see that along with the time this group is redistributed. That means that infections rate is going to the elderly people and it is diluted. So this is the first hypothesis that was used for epidemiological forecast. And then further, how can we understand these values that we've used, and how can we compare them? I compared them with the probability of death. The blue line here is the probability of getting an infection, and the left side is males, and right side is females. And death is the red line. And we can understand here of the progradients of this event of getting an infection, how it is connected, or how can it be measured with the things like death. So 5,000, that means at the age of 35, 5 men out of 1,000 is dying. And the blue line, which is 2 times less, this is the possibility of getting an infection. And the second picture is also a rather interesting one. Why do I show it here? There is a cumulative, accumulating effect of death related to the age. The red line is, along with the age, how many people are dying, along with the aging, how many people are dying. So as of now, so at the age of 40, we can see that 100,000 people are dying at the age of 40. Then until 60, we have 300,000 deceased person, men and women. And the blue line is showing the annual rate of HIV infections, new infections, I mean. And here we see that because in the elderly groups, the infection is at the zero almost. So from 45, we are seeing this plateau. What is the particular interesting here? It's interesting for us to look at this. We've been oriented for the year 2019, according to the data that we had, just that approximately 100,000 infections cases, new infection cases we have in our country, and this is a rather huge amount of infections. What does the model make? It is redistributing the quantity along the age pyramid, adds new cases, and according to the decrements, it is calculating the rate of deceased persons and the quantity of the groups. And knowing the quantity of the groups, we are multiplying or we are meshing this with costs, and we can then calculate the costs for the patients. And the basis here is represented in these curves. So now we were speaking about the probability of getting an infection, and the second outcome is it is also the massive of the initial data. So primary initial data for the distribution. We took the informational bulletin. And on the basis of the informational bulletin, we've made the initial distribution. By the way, it looks like the profile of the rate of probability of getting an infection that we've seen before. And in the year 2019, we've used this form, taking into account the density of distribution, to make the distribution of our initial groups, initial quantity. Initial quantity was 1,050,000 people. So this was just the initial quantity where we added 100,000 annually, and then we followed the dynamics of the disease. And so what did we arrive at? After creating this demographic movement, we've created several demographic scenarios. And I want to state from the very beginning that in these tasks, the task of that kind of class of social dynamics or social tasks, and by this I mean many global systems, it is a rule to work on the basis of scenario modeling. Scenario modeling is just rather a set of assumptions that are preserved during the period of a forecast and that define the parameters that are interesting for us for some reasons. Here we were taking into account these apt scenarios. And I will show you later also the other examples. But these, the first scenarios, are the classic ones. So we have 4 basic scenarios that are provided here on the screen, and they are differing by the fact that we were using hypothesis of the connection between the share of the patients who are getting the antiretrovirus therapy and the infected. And we use the 45% hypothesis that 45% of people infected are getting antiretrovirus therapy, and it has not changed a lot. But then in the next scenarios, we tried to build the new parameters on the basis of this hypothesis. We created like the scenario for 70%, for 90% antiretrovirus therapy in the second and the third scenario. And the last, 4th scenario is just a benchmarking scenario for us, according to which we were assessing the state when the probability of getting an infection is at its 0, for example. It's close to the 0. And here in this chart, we see the demographic and financial assumptions that were used for every scenario. I already told you about the demographic scenarios, and financial scenarios are the main costs as follows. The costs at the phase of HIV per annum per person 60,000 rubles a year, and in phase AIDS 200,000 rubles per year. And these periods of being in phases HIV AIDS are used within the mesh of the decrement death. What did we arrive at? And then we will see now the graphs. The quantity is in thousands of people, and the financials are in millions of rubles. So the first one, here we can see 5 lines that are correlated to the scenarios that we took into account, and the fifth is the scenario from demographic modeling of the HIV. Without taking into account HIV. What can we do right now? We can see the affection rate of the scenario of the overall demographic losses. And we're pretty sure here that the difference between the scenario without HIV and with due regard to HIV is the difference of 2 million people. That means 2 million people for 30 years is a significant demographic loss that is outlining the task for us, and that is stating that this particular task is very serious for us, and in the long run this problem will only grow. And here is the next graph that shows us how the quantity of economically active population is changing. And here, taking into account the coefficient of economic activities, of course. And here, the effect is 1 million between two scenarios, with HIV and without HIV. And we see here also the affection of antiretrovirus therapy and how it affects the population. Here on this particular picture, you can see the assumptions that we used for modeling on how the probability of getting an infection will be changed along the years. And the lower line, as I told you, the yellow line, is representing the 5% that correspond to the maximum scenario at which we are not getting rid of the HIV, of course, but we are significantly decreasing the processes of HIV. And the previous scenarios are corresponding to the shares of antiretrovirus therapy that are provided on the graph on the legend. So what did we arrive at? So using all this, the first picture here is the dynamic of the quantity. This quantitative measure is representing a scenario forecast that show how the overall quantity of HIV-infected persons will be changed depending on the share of antiretrovirus therapy for the whole group. And we can see here that if the probability of getting an infection is decreased not so much, the quantity of HIV-infected person is growing, and the gap between maximum and minimum scenario is a relatively huge one, approximately 800,000 people. And here, there are no serious reverse bindings that are taking into account the antiretrovirus therapy and this probability. This is just the hypothesis that I have showed you before, and this is one of the questions that needs additional clarification, and it needs more serious and a more in-depth study. But just to show this effect, to take a look at the specificity, for example, we've chosen this set of parameters in terms of quantity. And the next is the quantity of the patients having AIDS. And this was the same ideology that was used. We have shown the difference between the maximum and minimum scenario. We have shown that we are achieving a certain high growth, and this initial growth is bound to the fact, perhaps, that we have more affection of our suggestions with the reality. But there is a huge gap between these results also, which you can see on the slide. And it also needs more in-depth analysis here. What about the costs in HIV phases? When we take these 60,000 initial rubles per capita, we see the following costs. And the results are pretty much the same. They are fitting into the logic because previously, initially, the share of the costs is lower, but when we have more antiretrovirus therapy, the costs is getting higher. And taking into account the quantity of HIV-infected persons, we see this is just the analogous to any kind of investment. And pretty much the same logic also is related to the costs in the AIDS phase. And the overall costs that include also the so-called additional costs that are related to the prevention. And this was also calculating the growth rate and the inflation. These are not discounted flows. These are the flows without taking into account the growth. But these are the real numbers, and we have an assumption that the rate of the growth is combined with the discount. And just a couple of words about the methods that we see as most perspective ones for the building up of a model and analysis of the versatile system. This is a shift from scenario modeling to the meshing method. What is meshing method in our understanding? Meshing is just comparison of a mass of variants or analysis of specificity for multiparametric tasks. And according to the horizontal axis, we have the year, and the vertical axis is the share of antiretrovirus therapy. And on the lines, you see the quantity of HIV patients infected with the years. You see the solutions. You don't see the scenario lines here. We just may build a trajectory and see how it will be changed. As a matter, it provides for analysis of multiple variants and for the sparing of our time on the analysis, on the work related to the analysis of the results. So this is just a step-by-step analysis, and this instrument is applicable for the tasks related to the calculation and multiple scenario comparison. And the same pretty much about the demographic losses. We see that along with the growth share of antiretrovirus therapy, we see that there are less losses in demography. And this is also a very vivid visualization of the results that we are arriving at. Similar about the death toll of HIV, and just a couple of words about how we did it. So what was the software that we used? We've created and developed the special tool, may I say like this, with the work to work with the big data, so masses of data that are made for the creation of the initial profile of probability distribution hypothesis of shift. And this program provides for construction of a demographic forecasts. It lets us to work with different distributions. For example, we've calculated here some for Russia, overall for Kemerovo region, for Sverdlovsk region within Russia separately. And this program in particular has a very neat graphic interface that provides for the analysis and assessment of the results obtained, and it let us also look on different parameters like scenario and parameters. We can alter the parameters and assess them together with the scenario. This is the tool that is letting us to increase the speed of the process of the analysis of data and provision of the reports. So what are the main outcomes? I don't want to comment on the outcomes related to the dynamic per se, but I wanted to state the following, just one interesting fact. If we will take a look at the influence of the process of HIV infection on the demographic losses, we may compare it to the following. Until now, we are seeing very high mortality rate in the most active parts of the population, and our losses, overall losses, because of the HIV and AIDS, are resulting at 200,000 deaths in the age from 20 to 50 years old and from 4 to 5,000 in the age from 20 to 60 years. And this is the amount of death that corresponds to the level of mortality that we have right now. But if the mortality rate would be in Russia and the level of the European countries, these losses would be significantly lower. This would be on the level of 150 or 100,000, which means that HIV is also introducing its own toll in these losses, in the losses of most productive population. But it is not so critical as other diseases. But at the same time, I want not speak about diseases. Perhaps it's just I'm not correct here. Diseases also, but other reasons. Therefore, undoubtedly, in terms of demographic development, in terms of the decrease of losses or losses in the demographic capital and demographic stock of the country, we need to work with these problems. We need to work out solutions and study this. And this was just an example of how we could use different instruments, also software, to make this analysis. I think that's all from my side. Thank you very much. Thank you so much. Unfortunately, we took a little time from the other presenters. You are not getting some additional questions. It's okay for me. But if you will want to, you may answer the questions later. And the next presenter is Gashnikova Nadezhda Matveyevna, with the topic Specifics of Molecular and Epidemiological Incidence of HIV in Kyrgyz Republic.
Distinguished colleagues, good afternoon. I need to manage my presentation, to control it. Okay, I think it works. Thank you. This research has been done in cooperation with the professionals of the Republic Center and local centers in the Republic of Kyrgyzstan, as well as with the participation of the employees of Vector Scientific Center. The main goal of our research is the molecular and epidemiological analysis of the development of HIV epidemic in the Republic. We had to understand the inner characteristics of that. We need to comprehensively study the clinical and epidemiological data of the patients, as well as the viral characteristics that were marked and identified among those patients. We hope that this understanding will allow us to develop some proper measures that will result in some great efficiency of preventive activities, and they will also help us to increase the effectiveness of ART. Well, we have, of course, the territorial specificities in Kyrgyzstan, and we've chosen Bishkek, Churska Oblast, Osh, and Orskaya Oblast, or regions. And the employees of the AIDS Center gathered the patients for this study, and they analyzed the data from these patients. It allowed us to understand that the collection of data and samples allows us to properly analyze the HIV situation in this country, I mean in Kyrgyzstan, and to draw the subsequent proper conclusions. So in the sample of the viruses that was studied, they were specific for the Central Asia countries, and they are called circulating recombinant form. And they accounted for 59.8% CRFO2 Ag, and the HIV of subtype A6, which is quite close to the Russian viruses, accounted for 33%. There are also some minor variants and options, and we've seen that the most majority of the viruses was among homosexual contacts. When it comes to heterosexual contacts, we've got some cases that were brought from Russia, and as well, among the heterosexual contacts, we've indicated some unique viruses or unique recombinants that occurred because of the repeated infection of people with the recirculating viruses, such as subtype A6 and O2AG. When it comes to homosexual contacts, we saw that the picture was quite a different one. There prevailed the A6 subtype. The second place was occupied the recombinant virus 02AG. And when it came to minor variants, the picture was quite different. The broad viruses, the broad European viruses was registered there, and also there was appearance of recombinant viruses that appeared because of the repeated infection of people with the 02AG and A6, and as well as the variants and options that were brought from the outside the country. For the main genetic variants of the virus, we comprehensively analyzed the epidemiological characteristics and clinical characteristics of patients that were diagnosed with these viruses. So for A subtype, we've seen that the viruses that were diagnosed among the population in Kyrgyzstan, fortunately, I don't have the opportunity to show you, but I'll show with my friends, or with my hands, sorry. Fortunately, the sound is coming very poorly. So the viruses in Bishkek and in Osh are marked by blue and red, and you can see the picture. So the blue line is viruses of Bishkek, and the red line is in Osh. The green line are viruses that were identified in Jalalabad. And here we see that the viruses that were diagnosed in Kyrgyzstan can be organized in clusters, but those clusters are not statistically supported. We see that there is a very heterogeneous picture of these viruses, and they are mixing with the viruses that were diagnosed in Russia and other countries. This means that the virus of the A subtype comes and is brought to our republic from the Eastern Europe as well as Central Asia, as well as it circulates inside the country. For A subtypes viruses, we developed and designed a phylogenetic curve, and we analyzed the time when this virus first appeared and when it started to spread. Well, the spread of this virus started in 1995, and we see that up until 2015, on an annual basis, the spread of this virus has been increasing, and after 2015 we monitor the negative dynamics in the spread of this A6 subtype. As to another main variant in the Republic of Kyrgyzstan, the circulating recombinant form 02AG, well, the situation here is quite different one. Here on this diagram we can see 4 clusters, and they're marked with the letters A, B, C, D, and these clusters are statistically supported, and it means that these viruses were brought to the territory of Kyrgyzstan, and after that they started to spread inside the country between the citizens of our state. Here you can see the phylogenetic curve of the spread of this type of the virus, and it shows us that the beginning of the epidemic that was caused by this virus happened in 1997. And we see that the clusters of the sources of this virus that were formed, it all dates back to 2000 and 2003. And the clusters, those were the Osh clusters, and clusters in Bishkek appeared in 2005 and 2006. One needs to say that the general analysis allowed us to identify the connection, a time connection of the drug traffic across the northern way. So the appearance of the sources of the virus coincided with the narco or drug traffic across the northern way. So we suppose that the drug traffic resulted in the bringing to the Kyrgyzstan of this virus. And we believe and conclude that the main factors that started the epidemic at the very beginning was such factors as the involvement of our country in the drug traffic and the penetration of these viruses inside the Kyrgyzstan to those groups that took drugs. So these drug-consuming people in 2000s, among them 80% were HIV positive. Another aspect is the labor migration, added and supplemented by the low level of awareness. So in the beginning of 2000s, there were some outbreaks of HIV, indeed, and it resulted in the spread of the virus inside our republic. So one needs to state that this virus that we call the Central Asia variant of the recirculating recombinant form 02AG, it spreads only in the Central Asia countries, such as Kyrgyzstan, Kazakhstan, Uzbekistan, and Tajikistan. We conducted a full-fledged phylogenetic analysis of all AG viruses, those that we could collect from the international database. We added it by our sequences that were decoded, and this analysis shows us that indeed there is a specific population of the virus on the territory of the Central Asia. At the very lower part of this diagram, we see the appearance of those viruses that are already spread in Africa. This is an absolutely different type of phylogenetic tree. And those viruses that are identified in the Central Asia, they build their own branch, but also within this branch, there's statistically significant group of the subtypes of this virus. So the Central Asia countries see the emerging of its own epidemic with its own viruses, and these viruses need to be studied in the future, and it will allow us to understand whether they are diagnosed properly, are there any characteristics of specifics of this virus when it comes to ART. And additionally, within this work, we analyzed the transmission clusters of HIV. So whether the transmission of this virus is identified among the population that has been studied. In the group that we analyzed, we found 59 possible transmission clusters. And it's evident that the majority of them, 39 clusters, were identified in connection to 02AG. And this is another confirmation that this virus is quite actively present in our country, in Kyrgyzstan. And 19 clusters contained viruses with a medication resistance or multiple medication resistance. And it tells us, it demonstrates that the transmission of primary resistant viruses is also possible. So what conclusions can be made of all this? The growth in the HIV infection is due to those viruses that brought to the country, but at the same time, the inner circulation of HIV infection adds more to the pandemic and to the spread of this situation. One of the most efficient measures on the prevention of HIV infection spread is the decrease of number of people that have quite a high viral load. And when we studied this viral population, we couldn't help but noticing that there were some mutations that are connected to the resistance, the development of the resistance of this virus. We conducted this kind of analysis, we described all these mutations, but I don't think that this is the most important element of our work. The most important one is that our molecular and genetic research of the virus allowed us to identify some gaps, loopholes, when it comes to the treatment of patients, as well as the analysis of the therapeutical efficiency. Each time when we discuss the results of the research for another group and sample of patients, we analyze all the characteristics as well as clinical characteristics of patients. And we've noticed that patients that administered ART on a regular basis, who were respecting all the rules, well, they have the proper viral load. And the analysis of the resistance allowed us to identify some viruses with the mutations among only 30%, and or from 15 to 30%. And when the ART was administered, it worked quite a lot for the upcoming 5 years and more. But it raised a suspicion, and we suggested that those patients were saying that they were administering the therapy, but they didn't do it in the reality. And another significant and meaningful conclusion that we drew is that among those people who haven't got any identifiable viral load with the test systems over 500 copies of RNA, from 15 to 30% of the viruses were resistant. As to the hidden refusal from ART, actually this was confirmed, because patients who were coming to a doctor for another dose of ART indeed confirmed that they didn't take the therapy for many years. They just took the medication but didn't administer them, because those medications were handed out jointly with the motivation packages. And as to the second suggestion about the test systems, indeed, these test systems didn't take into account the low reproduction of the virus, and they allowed to miss the initial development of the viral resistance. And so the AIDS Center analyzed additionally some other factors and identified them when it comes to the inefficient therapy, such factors as the frequent change of medications, drugs, also the untimely corrections of the therapy among children. All these factors that were identified were used for the development of new programs aimed at increasing the motivation of patients to administer the drugs, as well as to get rid of the gaps and loopholes that we identified before. And the data that we got from the project has been actively used by the employees of the AIDS Center to tell the patients that the repeated infection is quite a dangerous one. Also to tell them that labor migrants can bring in some new viruses. So all the information that we got from our research, we modified it into a user-friendly form, and doctors were telling the patients about all this. So the joint research allowed us to implement the new molecular and epidemiological approaches. It helped us to understand the epidemic, to understand the epidemiological process, as well as to develop some new and efficient measures. And one needs to say that all this was quite new one for us, not very understandable, but very useful. Back in 2016 and 2017, the employees of our AIDS center didn't have any experience in applying these methods, and they didn't analyze the inefficient therapy. And I do hope that this experience that we got jointly added to our main efforts. And currently, Kyrgyzstan gains some good results. If we take a look at the data of 2021 of patients with ART, we see that more than 80% of cases we identify so-called non-identifiable viral loads. So the therapy is efficient. Thank you very much. And thank you very much for your report. It was all very interesting. Thank you for telling us about the benefit of molecular and epidemiological measures. And our next report will be on the using molecular and genetic methods for HIV surveillance. It will be presented by Dmitry Kireev. Thank you very much. Shortly, I'd like to comment.
Recently, together with Natalia Andreevna, we were speaking about the originality CRF02G, and we arrived at the conclusion that perhaps there was a secondary recombination of the European CRF02G and recombinant of A103G, and CRF03G is the Asia recombinant of A3G. The recombination scope are pretty much the same, but CRF02G is just a different one, so this could be the case. Distinguished colleagues, give me 6 hours to cut down a tree, and I will spend 4 hours to sharpen my axe. This is my initial status, and the majority of the slides I will show you about, I will tell you about the axe. Here, about molecular genetic methods, I will speak about sequencing of HIV and further analysis of these nucleotic chains. Classically, we are sequencing according to Sanger, and we are using right now also mass parallel sequencing, and these new gadgets are providing for more patients by tens, dozens and hundreds of times. And generally we are speaking about sequencing of not all the genome. We are sequencing only main genes of protease, and the second one because there is the main question, and we are sequencing with practical goals to understand the sustainability and susceptibility. And according to these new gadgets that have more power in them and that have more possibilities to test as more people as possible, during the last 10 years we collected vast majority of nucleotic chains, and this quantity of nucleotic chains is providing us for conduction of a serious molecular biological research. The sequencing share people of the living in Switzerland is about 50%. In other countries, there are about 20%. Unfortunately, in Russia, there is only 1% of such people who've got their sequencing, and the density is playing here a very important role, because when we will want to conduct a national social survey, naturally, it is not enough for us to speak with 10 or 100 people. We will need to speak and to make a survey of a share of population. Also here, for serious research, we need a density of collection of 15, 20 or 30%. It is not recent research that epidemiologically connected patients have similarities in viruses by 97% similarities, and this is logically because the human being can provide only the virus that it has in itself to the other recipients, and after years these viruses tend to remain more genetically relevant to each other as the others. We are comparing on the basis of phylogenetical analysis. We arrive at phylogenetical 3, And 3, if we see that the several samples of virus are close to each other and they are differentiated from the other, we name it as a molecular cluster, and we mean that this molecular cluster is a part of an epidemiological cluster or epidemiological chain. And mainly speaking, we may see it as a phylogenetic 3, as you can see it on the right, or we can represent it in a more standard way as the clusters that you see here. And we can also understand that the more consequences and chains are in cluster, the more active is the distribution of an infection. And if we put characteristics on this cluster within other data of patients like gender, age, region of living, date of infection, or the way of a transfer of this infection, we can characterize these clusters in a more full way, and we may understand and define how the epidemics is developing. And these clusters are taken from the small size, and here how a more serious work looks. This is a very important picture, but you cannot understand anything here with your eyes, because generally, for analysis of these clusters, we use specialized computer and bioinformatics programs. We may say that the start of use of phylogenetic analysis and molecular genetic methods in the scope of HIV infection was started in the 90s, when it was started to make an understanding of the outbreaks of infection. One of the cases is the dentist case in Florida. The dentist who had the HIV infection, he was sequenced then with his patients that were also getting a virus from him. And then in 15 years, there were tens or dozens of this work published, and hundreds of them were conducted. And after 15 years, there was a norm and regulative document that is stating that the use of phylogenetic analysis can be used as evidence in criminal investigation of HIV transmission. And as I may state here, the presence of this document of HIV forensic is a good proof that phylogenetic analysis is a firm and sustainable instrument in criminalistics. And we have also this document in Russia. It's a bit, it was created a bit later than in Great Britain. 15 years, in 2015 also, the scope of use of molecular methods in epidemiology is broadening. This is not only an epidemiological analysis, this is phylogeography, study of the distribution of HIV, phylodynamics, study of the speed of the virus in on the planet Earth and in the several susceptible groups, assessment of main epidemiological parameters like basic efficient reproductive affection and so on. And this is also the definition of efficiency of diagnostics. That means a timely manner of HIV diagnostics. And it is also the brilliant possibility to assess the efficiency of preventive works. We all know this research, series of researches N equals N, where it is stated that N means non-defined doesn't mean non-virulently loads. If you don't have a virus load, you cannot infect your partner. And this was also the proof that was phylogenetically proven, but only by means of molecular methods we could prove that the partners were getting their HIV not from their partners with non-detected viral load, but from third persons, from the other people. Just a few examples to this. The first example of how we could trace the patient 0, the patient from whom the epidemic started in the Northern America. It was 1969, 1970, how the epidemics was developed in the USA. This is a very interesting work, 1970s, in patient 0 HIV1 genomes illuminate. reporting early HIV/AIDS history in North America. This is also the case for the USSR. There is a pretty similar work and paper related to the USSR history of first HIV in the USSR, and there was also the Kinshasa studies about the 1920s and molecular methods that studies Kinshasa case, and practical work that was done on HIV-infected patients from Uganda that are living near the Lake Victoria, and there is a very interesting population of people living with HIV because these are the farms that are characterized by huge affection by HIV. Up to 50% of adults are infected. And the other villages have also a huge affection rate, but not a catastrophic, from 10 to 20% in adults. And the researchers were thinking that these hotspots, real hotspots here, are the initial ways of transmission of infection near this lake. And the specialists sequenced the significant quantity of people out of 4 villages. They compared these 4 initial villages with the 36 other villages, and they've seen the vice versa picture. It turned out to be the fact that firstly, this is the domestic epidemics. That means this is epidemic within an epidemic. So new cases within the villages, these 4 villages, and between the 36 villages, they are arising within due to the HIV-infected people who are living at the side of each other. And the imports of HIV is then made through the migrants, so HIV-infected migrants who are going there for fishing. So this is just a very important result of research, and it has a great basis, and it is published in the last year in the Lancet. And also the third example, this is an old work that was published in 2016 by the great Canadian explorers with Richard Hannigan. And this is a real-time monitoring of a transfer of HIV because of the hot spots or hot outbreaks. What did they do? They created an online basis where after nucleotic chains, a study, and I need to say that in the developed countries, when they are sequencing patients before the start of the antiretroviral therapy, the sequencing is made or just straightforward after the diagnosis is set. So after the diagnosis is set, the patients are sequenced, and there is a digital database which is filled in by the data of this particular kind of patients with the data of patients, and then regularly once a month they are conducting phylogenetic analysis. They are providing for assessment of molecular clusters, and they define the clusters per se. And the researchers made the clustering on the administrative regions in Canada. In green you see the clusters with 0 outbreaks in the last month. Yellow or orange, 1 or 2 new cases of infection. And red color is 3+ recent cases. And for Canada, 3+ is a huge quantity of infection. So they've seen this administrative region, and during the last 3 months there were 11 new cases of infection. And then these results were transferred to the practitioners, that means to the practical healthcare, to the epidemiologists, and these HIV-infected persons were found. 1/3 of them were not encompassed by medical support, and half of them were not taking antiretrovirus drugs. And this was corrected. Naturally, all of them were taken into account by the governing bodies and authorities. The majority of them started immediately their antiretrovirus therapy, and according to the results, in 12 months in this region, they've seen 12 new cases, recent cases that were close to the cluster. That means that the quantity of new cases were decreased by 3 times after these anti-pandemic events. And this is just a great example on how molecular means can help you. And then let us go to the epidemiological surveillance. In 2003-2016, there was a wave of such works and papers. Now there are more than 500 of such works and such researches publishing related to the molecular epidemiology of HIV. And in 2018 there was the first norm and regulating document that was published by the American CDC on how to detect and respond and analyze HIV transmission molecular clusters and what the practitioners in healthcare should do with this data. And in 2018, there was the second draft version. I will stress it out that it's a draft version of this guide. And already more than a dozen of the articles or papers that are related to the molecular epidemiology of HIV that are methodologically using these particular instructions that were drafted in this guide. And this is just the fruit of the last several years. And I think we are on the edge of the beginning of the high-scale introduction of molecular methods into the practical epidemiology. Just a little bit about our national bases in different countries. In different countries, developed countries, there are national databases. For example, Great Britain, UK HIV, that includes more than 150,000 sequences. CDC, and there is also regional ESR, a regional database, which consists of a huge amount of countries of Western Europe, Eastern Europe countries. There is also a Russian database, domestic for us. This is a microscopic compared to the other databases, but we try to build on this. And the function of these databases is to preserve and store the information on molecular data, depersonified data of patients, and further analysis. And at the end of my presentation, I want to state that the molecular methods, as I may state, is a powerful instrument that is more actively used in epidemiology. And the nucleotide chain of the virus is a very important objective characteristic of a patient. And here I want to speak in detail about the objective characteristics, because the patient may not know when he or she was infected. Patient may deliberately lie about the way of transmission of the infection, but nucleotic chain will not lie to you. This is the parameter that cannot lie just. And if you have a huge amount, a huge quantity of nucleotic chains for a certain region, to analyze this nucleotic chains, you may trace the patient, you may say what is the group that is represented by the patient, and you will know more than the patient, really. And providing for a storage of the sequencing and nucleotic chains that are now in place in the country, it will provide for a better consultancy for you. This will happen not in 1 month or not in 1 year, because this information has no shelf life. Also, the information related to the people who died already with HIV, who are not a part of epidemiological process. As of now, the data of 10 years old, for example, it is also very necessary for us to restore the data on evolution of the epidemics in the region under research. And it seems to me that the further development of epidemiological vigilance is also connected to genetics, to bioinformatics, because without this particular knowledge, we cannot analyze everything. Thank you very much for your kind attention. Artyom Tkachuk, are you here in the hall? Because here in my agenda there is the last reporter who is here. So he's not the hero who would sit for the whole list of our presenters. Do you have any questions? Do we have any questions to the presenters? So May I put a joke at the end? Look, there is a mid-Asian stem that was seen. Perhaps I would think that it was taken from some Sasquatch. There is some joke also out of the micro, but still, I may state, thank you very much for this very interesting reports. Do we have any questions still? Are we happy with today's session? Then let me thank all the presenters. Really, we had a versatile set of reports and presentations, but I think that many of you had particular interests in this topic. There were not many people offline, but I hope there are many people online attending to this event. Thank you very much to all of you for your patience, and we wish you good luck. Thank you.